because it is a public meeting, and the recording will be posted on the Commission's webpage shortly after the meeting. TPW may be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. Vicki Lowe, Chair of the Universal Healthcare Commission, will now call the meeting to order.
Welcome, Commission members. It is now 2:03, and I call the February 2nd meeting of the Universal Healthcare Commission to order. We will begin by doing a land acknowledgement. I would like to begin by acknowledging that as we gather today, we are all on the ancestral homes of Indigenous people. I have a privilege that not all Indigenous people have. I live on the land of my ancestors, the S'Klallam people, who have lived here since time immemorial. Indigenous people, despite being removed from their land where they lived, hunted, gathered, practiced ceremonies, and cared for community members, whether officially recognized by the United States government or not, continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington State. As we work to address health care in Washington State, it is imperative that we address the inequities of the past by understanding their impacts of the present. I invite each of you to learn about and understand the true history of the Indigenous land where you reside. Thank you. I want to give a warm welcome to everyone for joining us today. This is our 16th meeting of the Universal Healthcare Commission. And before we go over the agenda, I don't know if everybody knows this, but this is Kristen Peterson is moving on, and not from DOH, but from the Commission. And I want to give her some space to introduce her replacement from Department of Health. Kristen.
Thank you, Chair Lowe. Yes, not moving on from DOH. Thanks for the distinction. And really, I just want to thank you for the opportunity to have been able to serve on the Commission. It's such incredibly important work, which is why I'm really pleased that Dr. Tima will be stepping in to represent the Department of Health. This will really be a perfect fit for the role he has here at the Department of Health. He's part of our leadership team, and he's the Chief of Healthcare Innovation and Strategy, recently came to the Department of Health. He holds degrees in medicine, epidemiology, health informatics, and health service organization. In his new role at the Department of Health, he leads a body of work that fosters population health improvement and the development of a prevention-centered, resilient, and equitable health system. So I really think you're going to benefit from his insight and contributions, and just want to give him a warm welcome. Dr. Tima, I don't know if you want to say a couple words.
Yeah, thanks everyone, and thank you so much, Christine. I really appreciate all of your hard work and representing DOH at the Commission. And really looking forward to stepping in your big shoes and contributing to the work of the Commission. Really excited to be part of this work and looking to see the strategies we can move ahead to increase access in the state, both in the short term as well as see if we can achieve our long-term goals of really having a unified health system.
Thank you, Dr. Tima, and welcome. And Kristen, thank you. I think Mandy said it best, that we have appreciated your just calmness and, very logical input. So we will miss you, but I know I'll see you in other places. But thank you so much for what you've contributed here, and wishing you well.
Thank you.
All right. Now we'll go over the agenda. First, we'll begin with roll call. But I would also like to use this opportunity, as we have been doing, to allow commission members to help get to know each other. Since we've been meeting virtually, it's a little bit harder to kind of gel as a group. So this is our opportunity today. When Mandy calls your name, can you also let us know what will you be doing this year that excites you, either personally or professionally? After roll call, we will vote to approve the December meeting minutes or summary, and then we'll have public comment. After public comments, we'll work to vote to adopt our 2024 work plan. And then we'll hear updates from the Financial Technical Advisory Committee, or FTEC. And they had a discussion on Medicaid. And so Pam McEwen is here from the FTEC to share that. And then we'll hear updates from each of our members who work with different agencies. And I bet some of that will be pretty legislatively focused. And then we will dive into our first transitional solutions topics, and that it is administrative simplification. Finally, we'll discuss benefits from the benefits and services category of the Universal Healthcare Plan development. And again, as always, I encourage each of our members to ask questions and provide feedback. And we want to, your job here is to talk and ask questions and help us come to solutions. So we hope that each of you participate. And those of you who've been here all along know I'm going to call you out if I don't hear from you. So with that, we will pass it over to Mandy to go through roll call. Mandy?
Thank you. Good afternoon, commission members. I will call members by the first name in the order listed on the agenda, which is alphabetical order by first name. When I call on you, please unmute your microphone and let us know that you're here and what will you be doing this year that excites you, either personally, professionally, or both. Chair Vicky?
I am present. And I don't know if this is exciting, but we are working to establish the Washington State Tribal Opioid and Fentanyl Response Task Force this year. And the American Indian Health Commission, where I work, will be the staff to that task force. So I'm excited to see all the work that we've been doing to be pulled together under one task force, and so we can be more effective and efficient.
That is exciting. Senator Ann? Senator Ann? Benicia?
Hi, I'm here. I can't think of a specific thing that I'm excited about. I guess I always look forward to summer to do something fun with my family.
I have Charles or Kristen.
Yeah, again, Charles Chima, I'm here. Again, really excited to be part of this work and excited about my new role at DOH, which is really geared towards aligning the public health and healthcare system to improve health in the state. So just excited for what the year will bring.
And Kristen, what excites you this year?
Oh boy, I wasn't prepared. Gosh, just a lot. Just looking forward to 2024. And as we move, I think it's a pivotal year as we move out of COVID, at least coming from the Department of Health, really rethinking our work. And also really excited that we established a new Office of Tribal Public Health and Relations and just named our Executive Director, Candace Wilson, to lead that office.
Wonderful. Dave?
Yes, I'm here. I am really excited professionally. There are a lot of things in the PEV&SEB programs that have been in motion for years and conversations that have been in motion for years, and looking like we might be able to turn some corners in some very positive ways for tens of thousands of hundreds of thousands of people. And so that's always really exciting to start to see the finish line maybe of some positive work while also setting up the next racetrack. So, just keep going.
Thank you. Senator Emily? Senator Emily? Estelle? Estelle? Jane?
Hey, everybody. Hey, everybody. I'm going to be totally and completely selfish and say that what I am looking forward to is a trip that we are planning to Scandinavia in June, where I will be able to see a very close friend of mine from law school who lives in Stockholm. And I'm selfishly not saying anything about work because it's the middle of session and it's totally insane. And so I'd rather focus on what's going to happen after session.
Well, that does sound exciting. Joan? Oh, I know Joan is running late to this meeting, but she will be joining us shortly. Representative Joe?
Rep Schmick and Rep Pacelli are sitting in House Appropriations Committee meetings as we speak. And I'm thinking Senator Randall, I think she's on Ways and Means.
I
So,
did hear from Representative Schmick that he may not be able to attend. Now
Yeah.
hear from Representative Marcus. I'll just give his name 1 minute. All right, Megan?
Good afternoon, everyone. Pleasure to be here. Megan Matthews, my pronouns are she and her, and I'm the director for the Washington State Office of Equity. One thing I'm looking forward to is getting out. So last year we had to focus on hiring. We were a team of 12 in May, and as of today, we were a team of 34. So we did an incredible amount of hiring. And now, since we have so much capacity, I can actually go out and meet people and attend events and establish and build those relationships. So that's what I'm looking forward to, because as an extrovert, I like being with people and meeting new people.
That's great. Thank you so much, Megan. I look forward to seeing you out and your team out. Mohammed?
Hi everyone. Yes, I thank you. My name is Mohammed Shidani. I'm actually looking forward to the whole year 2024. I'm hoping to see a lot of change for all of us in Washingtonians. A lot of improvements in healthcare access and economic opportunities. But most importantly, I'm looking forward to also to the warm weather and going out and seeing people and doing some work outside. Thank you.
I'm looking forward to that too. Stella? Stella? Thank you, everyone. I will turn it back to Commission Chair Vicky Lowe, who will facilitate review of the meeting summary and public comments.
Okay, thank you, Mandy. Thank you, everyone, for participating in the questions. Please join me in turning to the second tab in your commission workbook. The recording of the last meeting has been posted on the HCA webpage. We will vote on approval of the December meeting summary. Or is there any discussion of the meeting summary or any proposed changes? And if not, then I'm looking for a motion to accept.
so moved.
All right. And is there a second?
If I can find my mute button, I'll second.
Thank you, Dave. All those in favor say aye or raise your hand. Aye.
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 Right. Any opposed? All right, motion approved. Next, we'll move to public comments. The public comments received since our last meeting can be found under the third tab in your meeting, your commission book. So I open the floor up for public comments. We allow individuals to sign up to provide public comment before the meeting. And we will start with those who have signed up to provide comments. If you have not signed up and would like to provide public comment, please raise your hand. Then Mandy will call on you after we hear from the individuals who signed up ahead of the meeting. When you're called on, please state your name and an affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You're also welcome to provide comments in writing via email at any time. To ensure that everyone has a chance to speak, there is a limit of 90 seconds per person, which may need to be reduced if we get closer to time and we haven't gotten through the public comments. There will be a display of a timer as a reminder of your limit. When the timer stops, please wrap up your comments. We encourage public comment to be focused on the materials and topics being discussed today. We may run out of time for public comments. If we do, you are welcome to submit your comments in writing. Mandy, would you please start with the names of the individuals who have signed up for comments?
Yes, I have Aruna Bhuta. Aruna?
I don't see Aruna in the waiting room, Mandy.
I will move on to the next person on the list, Liz Murphy.
Yes. Hi, everyone. My name is Liz Murphy, and I'm a member of Washington Community Action Network. I appreciate this opportunity. I have been experiencing medical issues since about the age of 6 when I had my first kidney surgery and a diagnosis of type 1 diabetes a few years later at age 11. And since then, I've had pretty much a full-time patient kind of a life. In 2015, I received a double organ transplant. I received a kidney and a pancreas. It saved my life, and it's a miracle, but it's not a cure. And at this time, I am experiencing rejection of my kidney. This means I will need another transplant. That could be a few months or a year or two away. I am currently insured by Washington Medicaid, which will only cover one transplant during my lifetime. One solid organ transplant. And I will be currently eligible because my last transplant was covered by employer-based insurance elsewhere. But this means this coverage drastically reduces my life expectancy, even though I have loved ones willing to give me another organ. And that's because organs from deceased donors only last about 8 to 10 years. So for this reason and a lifetime of medical debt, I believe everyone needs a single payer system. Thank you.
Thank you. Chris Curry.
Chris Curry, speaking on behalf of lots of discouraged observers. I hope you can hear me. I hope this isn't news for any of you, but it needs to be out in the open and dealt with ASAP. This commission is stuck in neutral. It's not made a substantive decision regarding program design since it started some 25 months ago. It has been ignoring the accomplishments of the work group and despite numerous requests, consistently avoiding laying out a long-term work plan with specific sets of endpoints. Instead, it has spoon-fed copious amounts of background information by consultants who display no knowledge of single-payer health systems and who even tried to convince work group members that single-payer option A is infeasible. Consequently, members have no time for adequate discussion or decision-making, and they have no clear idea about where this is all leading. It's like playing football with no yard lines, sidelines, or goalposts. The one goal that has been accomplished is that process move as slowly as possible. And to speed up the process, many of us successfully lobbied for a major increase in funding, but to date, there has been no accounting for how it is being spent. The numbers in the draft report were left out of the final report. Important decisions about eligibility are being in the distant future, so illusion of progress can be maintained. Commission members need to make a course correction before the things get any more embarrassing. Give the consultants the day off and have a serious discussion about leadership, direction, agenda setting, goals,
you're
and the
over
role
time.
of consultants and staff. Response.
Thank you. Turning to folks in the waiting room. Please raise your hand if you're interested in providing public comment. Didn't see a hand raised, but then it lowered. But I didn't see whom. If you raised your hand, it lowered again automatically. Give it one more chance in case somebody intends to. Lori?
It's Lori, Mandy. She's going to be promoted just a minute.
All right, thank you.
Should be good now.
Great, thank you. I hope that Chris Curry submits his comments in writing to you. I know that he often has trouble because of where he lives with internet connectivity. But I think the points that he made are really important. The working group was very clear in its recommendation to study in depth option A, single payer healthcare. Many of the advocacy groups that have been supporting the work of this commission are really behind a unified payment system. And I would really like to see some sort of timeline and benchmarks for the work of the commission as well as finding people who are really dedicated to the work of the commission and show up for these meetings. It seems like there are a number of people who are on the commission who repeatedly for some reasons, that we're not privy to, don't make these meetings. So I would like to see a team of people who are committed and actually show up and attend these meetings, as members of the public are doing, who care deeply about this issue. And then also we have a number of times made recommendation that when presentations are going to be made to the commission, that the commission view these presentations in advance so that discussion can actually happen during these meetings, and so that the public can be witness to these discussions so we can understand what the thinking is of the commission members. Thank you so much.
I'm not showing any other raised hands. I'll just give it a moment. Vicki, that's all the public comments that I have. Turn it back to you.
Thank you, Mandy. And so we'll close public comments. Thank you for those of you who were able to provide comments, those and the written ones too. And now we're going to welcome Liz Arjun from HMA to review the 2024 work plan. Liz?
See me? Thank you, Vicki. Hi, everybody. Thanks so much for all your comments and from the public comments, and for the commissioners sharing what they're excited about this year. I hope today adds to some of your excitement about what you'll be working on this year. So following our conversation in December, thank you so much. We had a very, I think, thoughtful conversation about how you all wanted to tackle topics for the next year. We solidified the areas of transitional solutions that the commission wanted to study over the course of the next year, because just a reminder, part of the legislative direction for the establishment of this commission requires that the commission evaluate transitional solutions that could help move the ball forward towards a universal system. So we got to that place in December. It took a while, but I think we have a good year planned out. The commission also agreed that the FTAC should play the same role in 2024. I'm sorry, that says 2023 as well. I'm sorry, that they played in 2023 and 2024, and focus their time and energy on universal design topics. And the first of those topics is benefits and services. The other thing we heard from all of you is that the commission would like to draw more connections between the long-term design work, what's happening with the transitional solutions and why they matter towards the long-term universal design, and the current topics that are being discussed and deliberated in the state. Next slide, please. So this work plan reflects, hopefully, that input. And just to orient everyone, again, last month was January. We had the FTAC meeting where they discussed Medicaid. And you'll see for every one of the commission meetings, the first item that will always be a new standing item is the standing agency updates. And this was based on your feedback, because we know there are several other policies that are being considered and discussed by the legislature and HCA, Office of Insurance Commissioner, Washington Health Benefits Exchange, Department of Health, that could have some impact on the work that you all are doing here. And the commission reinforced that it would be important for you all and for the public to hear about those efforts, because they could have potentially a big impact on some of the work you're doing. So you'll see that across the top. The first, and today we'll be talking about the Medicaid options that we received from FTAC, which would then conclude the work that the that the commission, that the FTAC has to do on eligibility, and we'll be turning to benefits and services. You'll also see throughout the work plan that we'll be hearing from Whole Washington about their plan and how they would approach this work and how that parallels or how it could inform the work that we're doing. We also, you'll see in our meetings in February, April, June, and on the subsequent page, the transitional solution topics that you all focused on. The first of which is administrative simplification. So we'll be hearing from some national experts today on the role, the importance of administrative simplification in and how it could improve provider participation, but also how it could lower healthcare costs. We'll be continuing that conversation in April and hopefully having some recommendations that will be part of the report that the updated report that the commission puts together later this year. The next topic that you all settled on, and this is beginning in June for transitional solutions, is maximizing enrollment in existing programs. And that included several sub-policies, one of which was auto-enrollment. And then I'm going to go back and forth. Why don't we go to the next slide, Angela? I think it's Angela that has the slides. In August, we'll continue that conversation on maximizing enrollment and talking about the expansion of programs that are being implemented for immigrants and what the status of that is and what needs to be done to really maximize that population getting covered. The last transitional solution topic area in October will be maximizing enrollment focused on the Medicare savings programs. I'm sorry, I said maximize, that's not the last one, but we'll be talking about Medicare savings programs. We've heard that from several folks and we'll be spending some time talking about that in October. And in December, we'll be talking about maximizing enrollment, and the subtopic is consolidating and expanding state programs. So that those are the topic areas that you all had decided as transitional solutions. And if we want to go back one slide, Angela, I can talk a little bit about the FTAC work and the universal design work stream that will be happening. So again, we'll be diving into benefits and services today and providing guidance and input to the FTAC. And then the FTAC will begin their deep dive on that in March. They'll be reporting out to the commission in April on their preliminary work, and then considering that again in May. If you want to go to the next slide, that'd be great. In July, we're hoping if things are moving quickly, we'll move to provider reimbursement for the FTAC. Again, that would be informed by, their discussions would be informed by the questions that you all as a commission have. And we would provide an overview to you about that in June. And then the FTAC would consider it in July and September. And similarly, the next topic would be focused on cost containment for the FTAC. And in October, the commission would get an overview of that, develop questions and considerations for the FTAC, and the FTAC would deliberate and discuss that in November and bring preliminary feedback in December. So that is the general work plan. I'm not going to go through every single bullet, but hopefully this approach resonates with the way we've tackled things the last year. I would say that we're much more specific in this work plan about what transitional solution is being discussed, and much more specific about the state agency updates that are going to be happening. So hopefully this provides a nice overview. And Mandy or Angela, you may want to help me out here, but the draft report with recommendations will include the information up through September, I believe, or maybe October.
It's through September, Liz.
September. Okay, so not all of the work that's happening this year is going to be reflected in the 2024 report, but hopefully a big chunk will be in there. And I just want to call out the asterisk on the bottom. The work plan is contingent on how much progress we make each time. So last year we were able to kind of tackle foundational issues kind of 2 meetings at a time. So hopefully that can happen again this year, but we will see. Any questions about this work plan? Any concerns or things that you want to make sure that are being talked about that are not addressed here? I know one of the things that came up in our February meeting that we may want to overlay with this is, I believe Dave, it was Commissioner Dave, it was your input in a conversation with a couple of folks about needing to reflect some of the legislative timelines or some of the things that are happening outside.
Yeah, no, I appreciate that. I think that I think that this balances that and provides some of that context. So, yep.
I have one quick question, I guess. I missed the meeting last time, and maybe this was discussed. So I see that there is something called Whole Washington Perspective in the February, like for today's, but I didn't notice any slides or anything about it for the meeting today's. Is that part of today's meeting? Is somebody going to give us the Whole Washington Perspective? I'm not sure what that is.
We heard from, well, Whole Washington, well, Angela or Mandy, do you want to speak up?
They presented at the last meeting of the commission, and we have them presenting on their financial plan potentially at the upcoming MTAC meeting.
Okay. And Badisha, there, Whole Washington is one of the advocacy groups that has been working on this, on the legislation that created the commission, and they've developed a plan. And one of the requirements, not requirements, but there was a request last year to make sure that the commission is more deliberately looking at the work that their proposal, as the commission does its work. So I'm sorry, it's a mistake that it was on this work plan, and for this month, we'll be doing it at probably the next one in April.
Okay, thanks.
So we're looking to have a vote to adopt this work plan. We just want to make sure if there's any discussion on the proposed work plan. Any other discussion, I guess. If not, then we'll entertain a motion. Oh, Megan.
I might be missing this, but does this show us what we plan to accomplish this year? I see review, updates, maximize, discuss, but I don't see like what can we expect to be accomplished this year?
So the process is like we pick a topic and discuss what we want to know about it. And then we send those questions to the FTAC, they review it and then send back recommendations to us. And then we discuss the recommendations. And then that goes into the report.
With recommendations from the commission.
Yes,
to the legislature.
Mm-hmm.
So we're driving towards the 2024 recommendations, Megan, and the 2024 recommendations would include, ideally, if we get the work done on the time frame that we just talked about, recommendations about universal design, including provider reimbursement. And if we can go back one, Angela, that would be great. Benefits and services, as well as transitional solution recommendations around admin simplification and auto enrollment for maximizing enrollment. So it's leading towards developing the report recommendations that then go to the legislature. So that's the main objective.
This is Shane, would it be helpful maybe, Megan, if sort of the items that were decision points for the commission were bolded? Just to sort of clearly communicate decision points?
We can do that in future iterations of this.
Or even include a little blurb like key decisions will be made on X, Y, and Z throughout 2024, or recommendations. Would that help, Megan?
Yes, thank you.
Also want to check in with Dr. Chima to make sure, because this is his first meeting. I know he's probably met with Kristen, but if this makes sense to you too, if you have any questions.
Yeah, no, I just had a similar comment to Megan. It was kind of really, it wasn't very clear. I think, but the solution we proposed could help with that. It's kind of calling out a bit more the top. They kind of buried it in the slides, so maybe calling them out a bit more. The topics that we're working on for this year.
Okay. So we can either add a front slide that says recommendations will be made on X, Y, and Z, or we can bold it, or we can do a blurb, or we can just do all three. It's not a big deal to do that, to just call it out.
Okay, any other discussion, questions, comments? Does everybody feel comfortable with this? Anybody feel comfortable enough to make a motion about it? Am I subtle enough?
I move that we adopt the draft work plan.
Thank you, Jane.
I
Any-
second that.
Thank you, Mohammed. All right, so there's been a motion and a second. All those in favor of approving the 2024 work plan, please say aye. Aye.
Aye.
Aye.
Anyone opposed? All right, we have a work plan. Good job. Thank you, Liz. So next, we're going to get our update from the Financial Technical Advisory Committee, or FTAC. Oh, we already did that. And so we have Pam McEwen here as the liaison to the FTAC, who's going to give that update. Pam?
Yeah, thank you. Good afternoon, Chair Lowe and Commission members. Can everyone hear me okay? Yeah, okay,
Yes.
good. Well, happy Groundhog Day. Today, I'm going to be reporting to you on FTAC's January meeting, which we discussed Medicaid, but I want to note that we actually worked on Medicaid for two of our meetings. It's a huge topic. And that our January meeting focused on the Commission's questions, which I think we have on a slide. If we can have the next slide. These we worked on for two subsequent meetings. So we heard, so I want to just kind of note that the questions really vary significantly in terms of one of them has some have like a yes, no answer, and some you could write a PhD thesis on. And so we worked on those kind of consulting with different experts, both internal to the state agencies and also external. So we heard from Dan Muse from Princeton, who presented to us extensively on the issue of what other states are doing in terms of their waivers, and was able to answer some of the commission's questions. We also heard from Michelle Needham. We heard from Joan Altman from the exchange. And then our last presentation was from Dr. Stephen Spivak, who helped us a lot with the provider rate issues. So we concluded that we did not have a comparison of benefits, which we are all wanting to get our hands on in terms of looking at Medicaid benefits compared to other programs. And so I understand some information is coming back to the commission in this area. And I can tell you the FTAC will be really interested in that, especially as we dive into the benefit questions. We have a great deal of information on waivers and spent probably maybe the bulk of our time on that topic. And we're able to pick up a lot of information on that will feed into our recommendations, and also looking into barriers that exist, particularly on the question of classic Medicaid and whether or not there was the ability to waive asset limitations for classic Medicaid. We have an affirmative response on that. There is lots of latitude to that. In fact, states have done it through 1115 waivers and also through state amendments. So there's a lot of possibilities in that area. I'd like to move on to the recommendations. I believe that's the next slide. So, actually, I want a little bit more on our findings. So, see, let me look at these quickly if there's anything that I missed. I guess one of the things I want to talk a little bit more about is provider rates. And the presentation that we heard really kind of dove into what's going on with providers who do not serve Medicaid clients. It's a surprisingly small percentage that do not, but there's a sort of a recalcitrance there that they have been reluctant to take Medicaid clients. You know, there's a recommendation that if you give them more money, then potentially they will take Medicaid clients, but we don't know that. We don't know if that would change their behavior. Sometimes if you're wanting to change behavior, it can take more resources than you imagine to actually get the behavior change. And at some point, you're targeting the resources to the providers who have really done the least for this community, as opposed to those who've done the most. There's very interesting Kaiser research recently, which is that during the expansion of Medicaid, there wasn't, and we didn't have an increase in providers. It just meant that the providers who were out there who had been seeing Medicaid clients did much more. They stepped up and saw far more people, which, and we know from the wear and tear on providers these days that that did take a toll. So I think that in conclusion, the FTAC really felt like we need much more information. We need to know, where are the barriers to access? Where are people not being served? Is it specialty care? Is it provider care? Is it primary care? And then what difference would it make to put more resources into different areas to, for example, to pay more for primary care or to target pinch points in specialty care? So we, are kind of that'll come back to you. You'll see that in one of our recommendations. The other thing I think that is interesting that we heard was that New Mexico recently heard from CMS that they would be allowed to expand Medicaid to 400% of FPL. Before we all get excited about that, we have to realize that New Mexico is a very unique state, significantly poorer than Washington State, and with a very different insurance market than Washington State. But regardless, it's still interesting, and it does raise the possibilities of what can be done with waivers, which was an area of significant interest for FTAC, coming back to all of you. Now I think we can move on to recommendations. So the first is, not surprisingly, is to pursue Medicaid waivers and SPAs as needed to include Medicaid. There was no controversy about whether or not Medicaid should be included in any universal program. The population is too large, too significant. The funding resources are too significant to not have Medicaid be kind of front and center in anything we look at for universal coverage. And that many elements that we care most about can be achievable without waivers. And then between the 1115 and SPAs, there are a lot of possibilities. So the recommendation is to consider pursuing Medicaid waivers and SPAs as needed. And then we're going to need to have kind of a dialogue back and forth, because it's hard to know where to jump in on the waivers until we have more details about benefits, costs, other programs. We need more details about how the commission wants to proceed on a universal program. But this should be front and center as you move forward and think about the inclusion of Medicaid. Next slide. Then evaluating the role of Medicaid rates and access to care. We think this is a really important area for as we look at Medicaid enrollment, particularly on two levels. One is moving forward to a universal system, but also in terms of short-term reforms that can help the program. So looking at payments and looking at access, and where there are access problems and where changes in payment could actually make a difference in access. And then finally, the transitional solutions, administrative simplification for Medicaid to help motivate provider participation. Administrative simplification can have two impacts. One is to help providers more easily participate in the program and be able to more efficiently participate in the program. The other is customer experience for the patients and clients who are in Medicaid. A lot of administrative complexity falls adversely on clients, and administrative simplification can also improve the customer experience. So I know this is a really important topic to the commission, that it's part of your short-term solutions that you want to pursue. And we recommend that Medicaid be part of that administrative simplification work that you have going forward. So there's, in short, there's lots more to come. We think there's a lot of potential in Medicaid work that's not there in Medicare and ERISA. So enthusiastic about working with you on this. And I'd be happy to answer any questions or listen to any discussions. So thank you very much.
Thank you, Pam. Does anybody have any questions for Pam? Megan.
What's needed for us to pursue waivers? I know HCA has done waivers in the past. Is that something that takes legislative action, or is that something that we can just do?
You are you're in a virtual room with a lot of experts on this topic, and Healthcare Authority has really a tremendous and impressive track record on pursuing and winning waivers for Medicaid. And it's something that's done, it can be done on an agency basis, but often it's done in partnership with the legislature in terms of informing as they go along. Because it can be, there can be multiple levels of change that come through a waiver. And in the materials that we add, I think they're under tab 4, the reports from the group, we heard extensively from Michelle Needham about Healthcare Authority's experience with this. And one of the things that I want to note is that a waiver is a multi-year project. And both going forward to win the waiver, it can take a long time. And then they need to be renewed so that it is a tremendous investment of resources by the agency.
Where a state plan amendment is more permanent, right?
Yes, it is more permanent and it's simpler, but sometimes there are things you just can't accomplish through the amendment that you can through the waiver. So and then you decide to kind of go all in on the larger effort.
Mm-hmm. Did that answer your question, Megan?
Yes, thank you.
Yeah, thank you, Megan.
Pam, thank you for so adequately and admirably describing the Healthcare Authority role. Thank you.
That's high praise coming from you, Dave.
Pam, sorry, I'm wondering if you also want to share that we broadened this thing from just waivers to spas because we realized anyway, if you want to just talk a little bit about that conversation, if it's ringing a bell.
It is ringing a bell. And also, I want you to finish that thought because you were saying it really well.
Yeah, one of the things that originally this recommendation was pursue Medicaid waivers. And after the discussion with and hearing from Michelle and from waiver expert Dan Muse, the recommendation was to expand it to state plan amendments because, as Vicki just mentioned, it's a much more straightforward way to get permission to change your Medicaid program. However, there are some trade-offs. And so the commission or the FTAC decided to expand it because they realized that perhaps there's a pathway where some of the things that the commission wants to do, the HCA applies for state plan amendments to achieve those, while in tandem pursuing the longer term Medicaid waiver that they may need for some of the larger initiatives. So that's why it's both.
Yeah, I really like that. I like how you put that, Liz, which is there's also a sense of how do you tee up these efforts, which is you may be able to do things that are through amendment initially while you kind of build the effort that would be required to do an 1115 waiver. The other thing I would add on to what you said is that I was really impressed with what other states have been able to do through amendments, particularly the District of Columbia. And I think it was, can't remember which state, it was Arizona that had actually been able to waive requirements for classic Medicaid in terms of asset testing through an amendment, which I thought was impressive.
Thank you. Any other thoughts or comments?
So I want to echo Pam's comment about sort of the role of Medicaid rates and access to care. And I think to the extent that we're spending time thinking about Medicaid rates and whether they do influence access, that we strongly take into consideration not just the direct reimbursement rates, but all of the supplemental payments that go out to add substantially to what base Medicaid rates are through things like dish funding and certified public expenditures and the recently enacted safety net assessment fund that went out to the hospitals. So thinking about all of that, and then Pam, sort of as a corollary of that, right, is if Medicaid rates can be increased, what does that say about commercial rates?
Yes.
Right? Because theoretically, we are told there is a cost shift
Mhm.
And so if we're relieving the pressure by increasing Medicaid rates, what does that say about affordability on like the PEB/CEB side and the commercial side?
That's right.
Medicare rates we can't control, but yes, on Medicaid.
Yeah, I think that, Jane, that's really, really helpful the way you frame that, and that there's really no way forward on a universal program without really looking at Medicaid and Medicaid's role and how we could, change things in a way. But every time you touch Medicaid, there are 15 other things that you've affected, and things that are longstanding in which people have care arrangements and payment arrangements organized around for years. So I think it's really important how we go forward and how we phase different motions going forward.
And I mean, the other thing I'll think about is, because it's front and center these days, is rural health clinics, FQHCs, we have figured out a way, tribal clinics, right? We've figured out a way to do encounter-based payments that are significantly higher than traditional Medicaid rates for good reasons. And I know there's lots of discussion about doing that on the behavioral health side with the local behavioral health agencies and the CCBH, I can't remember what all the letters are. There are a small number of demonstration projects on that, but I would suggest, as you're thinking about how we integrate Medicaid, what we need to do with Medicaid, that we think about how we can have that kind of equity between how we treat FQHCs on the medical side and how we treat services that are provided by behavioral health providers exclusively.
Right.
And I see Vicki nodding her head.
Well, and I had really wanted to bring up the FQHCs and cost-based payments. In the Indian healthcare delivery system, we have the encounter rate that's calculated annually at the federal level. But for like our purchase and referred care programs, we use what we call Medicare-like rates, which don't have anything to do with Medicare patients, but that we use because Medicare rates are cost-based, we use that for people who don't have coverage. So if somebody who's not eligible for Medicare or Medicaid gets referred out from a clinic, there's a federal law that allows the tribal program to pay Medicare-like rates, that has to be calculated by somebody. And I think even that is better than Medicare for specialty care providers. So we're working on a way of leveraging that Medicare-like rate. And I just think, I understand the safety net programs and all those other things. I've had some conversations with our CEO of the hospital up here about what global payments look like. There's so many things to consider. But I think the one thing that's important is in 1996, so this is like pre-internet days when I first started working in the Indian healthcare delivery system, HRSA made a ruling about FQHCs where it's called the one facility, one rate rule, because it's not okay to have patients get the same care, but have the provider be paid differently because of that. And we've really moved way away from that, but that we still use that ruling for tribal clinics. And I think I think that's where we're trying to go with universal health, but also there's so many things to consider because we've made the system so complicated. So how do we reverse engineer back to a more simplified system where providers can get actually paid enough to cover the cost of providing the care to people? And it's not the different coverages, kind of competing or trying to make the whole system equal. But I mean, that's a lot to think about. But Medicaid rates are not enough to cover the cost unless you have an FQHC or you're getting cost-based rates.
Yeah, one other thing that I would note when I was reviewing the materials and the study about the providers and their willingness to accept Medicaid patients, in any kind of work that I think we do on this, that was a study of independent providers, and we have fewer and fewer and fewer independent providers. And so I think the way we thought about increasing Medicaid rates 20 years ago, when the vast majority of provider practices were independent, is very different than thinking about Medicaid rates when probably the majority of providers are employees of either a hospital system or big entities like Optum Medical. Because then it's not the individual physician's decision about whether they're going to see Medicaid people as much as it's their employer's decision about sort of their revenue mix and who they're going to see.
Right.
So because of consolidation, it just changes in so many ways the way we think about questions like this.
I think that's a really important point by Jane, because one of the questions I was contemplating is, do we have data on Medicaid acceptance by different kinds of providers and systems, right? I know that generally we have concerns about, particularly in the private sector, about acceptance of Medicaid, but community health centers, at least from my experience from other states, oftentimes glad when they have people who have at least Medicaid coverage compared to being uninsured, right? So because that guarantees that they get at least some revenue, even though it may not be comparable to commercial rates. So I guess where I'm going with that is that perhaps some of the solution could also be looking at how Medicaid acceptance differs if we have data, or maybe that's something coming to there within the scope of further investigation is how does that compare, particularly in the FQHC settings with other providers? And is there room to also looking at increasing access through the FQHC system as one of the potential solutions? Besides just trying to fix Medicaid itself, is kind of looking at the provider side of things. Is do we have enough capacity in the FQHC system to help meet needs when, particularly in the medical underserved areas in the state?
Thank you. Yeah. Dave, did you have something to add? No?
No, not at this moment.
Okay. Anyone else?
Vicky, or Chair Lowe, I would,
Vicky.
I would just like to put in a final plug for busy commission members, particularly you have a number of people who were not able to be here today. Liz and Angela did a masterful job on this summary of a long, complicated discussion. I would really encourage people to go back and take a look at that if they haven't had a chance to do that.
Yes, thank you. That is a great summary. And I think we can watch the meeting still, isn't it, on the webpage? Yes. So if you're really interested in seeing the conversation, you can go to the Universal Healthcare Commission page on the Healthcare Authority website and see. And even if you miss one of these meetings, you can still watch it too.
And I don't know who in the world has time to do that. I mean, I hope you do, but if you did, I would really recommend Dan Muse's presentation on, I thought, what other states are doing. If you had time to, for one thing, I would recommend that.
Thank you, Pam. Yes. And thank you for being the liaison and bringing this information to us and answering questions. Really appreciate you.
Thanks. Thank you.
All right. Are we ready to move on? Any other questions, comments, or can we keep going? All right. So next on the agenda is a state agency update. So just an opportunity for each of our commission members who are working at the state agencies to give us any updates on anything that's happening that might impact the work we're doing here. We're like mid-session, so any legislation or programmatic operational changes. And Mandy just put the link to the webpage in the chat box if anybody's interested. So I do have a list here, and it starts with Dr. Chima, and I don't know if that's fair to make you go first in your first meeting.
Oh, it's fine.
Okay.
Yeah, no, we have, it's a busy session for everyone, and we have a few bills walking through the session, including one to give the secretary powers to kind of issue standing orders to address emerging public health threats. Think about kind of, some of the powers we had during the pandemic to address issues. So how can we apply that to other emerging public health priorities? Right now, I think those powers only apply to naloxone. So how do we expand that beyond the opioid crisis to some other challenges that we need to tackle in public health? There's also one about RSV. Essentially, how can we bring in RSV vaccination for children into the standard vaccination program, so that by doing that, we can then be able to negotiate better rates and get it more available to children all across the states. And another one worth mentioning is when there's another bill in regards to healthcare enforcement. Again, this is similar to other laws that have been passed, by the legislature, but it's kind of expand our enforcement options for certain categories of healthcare facilities. So those are just some of the bills that we're working through. But other than that, just a busy session, with everyone else. I'm looking forward to the end of the session. And if there are kind of more detailed questions about any of these bills, we're happy to connect with our legislative director.
Awesome, thank you. Any questions for Dr. Chima? I was listening to some of the testimony for the RSV, the vaccine. Yeah, there's been some interesting conversations. And let's see. So Dave, looks like you're up next.
Sure, there's so many different things that could be talked about. There's always just a few things that impact the healthcare authority. On kind of the commercial side, in that PEB and SEB space, there's quite a few different bills that are playing in the pension retiree healthcare space. Either funding as it relates to subsidies or changes to benefit structure that might help with funding pension sides of the equation. There's quite a few benefit bills that are in play in the commercial space. For example, the fertility bill that kind of stems from prior sister agency and healthcare authority legislative reports is, I believe, on the House calendar at this point. There is, I'm not going to steal Jane's thunder, on balance billing. I'll just say things like balance billing and provider contracting and anti-tiering and anti-steering and all the common areas that we talk about. I still won't steal much of Jane's thunder to talk about those areas, but those are things that we are very closely monitoring. And then there, although we haven't quite, the legislature hasn't quite moved into that budget, the full budget process quite yet. I know that some stakeholders that are here at the Universal Healthcare Commission have expressed interest or provided some advocacy on maybe some potential budget language that would maybe work on that incremental step of consolidating the PEB and SEB programs or providing insights. And so I think there's interest in that. So the agency's been providing some, technical support on potential language that might, who knows, we'll see eventually if it's there, but that's another thing that kind of relates to our work. I may think of some more things because there's so many different topics, but I think that's a good 60-second summary. Because Jane can take care of several others of those.
Yes, thank you, Dave. And that was your segue, Jane.
Okie doke. So I'm going to talk about one non-legislative thing, just to give an update. Remember at the last meeting, we presented on the preliminary affordability report, and we are deep into work with Wakely, who's getting started on the actuarial and economic modeling. And for purposes of the commission, one thing to think about is the budget proviso specifically directs that we produce a feasibility study on a global hospital budget model for at least one county or area. So what we're thinking about at this point is an urban county and then a rural region to try to really get a sense of what it is. And there'll be several other policy options that are being modeled that were in the preliminary report, not all of them, but some that are directed at insurers, some that are directed at providers, some that are directed directly at price, some that are direct affordability sort of more indirectly. So really the idea is to have a really nice array of options with what would it mean if it were adopted in Washington to present to the legislature next session. And we're happy, that's due in August. So we're happy to come back and work with Wakely to present what we find to the commission. And then on the legislative front, Dave's right. Big priority for us is filling the last puzzle piece in balance billing, which is ground ambulance balance billing. The bill is in Senate Ways and Means now. We're hoping it's going to come out on Monday. And as everybody would predict, the one issue remaining is how much out-of-network ground ambulance providers should be paid. And ground ambulance is a little bit different than your standard healthcare provider because they're there 24/7. And when you dial 911, you expect somebody to come. So it's been a really, really interesting discussion. I don't think that's going to kill the bill, but I just think we're going to have a lot of heart-to-heart discussions about it. And then on the admin SIMP front, I wanted to let folks know that what we are seeing, Representative Davis has House Bill 2319, Senator Dinger has Senate Bill 6228. And what we are seeing is a concerted effort to bring common practices across commercial health plans, Medicaid, and PEB and SEB. And so, for example, both of the bills would very, very clearly state that ASAM criteria are the medical necessity criteria for substance use disorder treatment. And both of the bills have the Healthcare Authority and OIC working together to develop a standardized common template that treatment providers would use when seeking authorization from Medicaid MCOs and private health insurers and PEB/SEB plans for coverage of residential treatment services. So there really is a significant oomph behind looking at admin SIMP with respect to access to substance use disorder treatment. So that's great to hear. There may be some activity on the Keep Our Care bill, which is Senate Bill 5241, which has the AG's, the Attorney General's office, doing much more active oversight of merger and acquisition activity among healthcare providers. And Dave mentioned there was a piece of legislation, House Bill 2066, that would have outlawed certain non-competitive provisions in contracts between health insurers and providers. That bill has been a challenge for the past 4 years. It still didn't move out, but it was one of the bills attempting to try to get at lack of balance, different levels of leverage in negotiations between health insurers and providers that patients unfortunately get caught right smack in the middle of. So I think for purposes of the commission, those are the things that I wanted to know.
Thank you, Jane.
You're welcome.
Any questions or comments? Especially the 2319, I've been following that because I mean that it has such a huge impact to somebody who's already been established as a provider at a level, at an ASAM level. You know, we make that argument with the MCOs all the time. Well, what do you know more than a tribal residential treatment facility? So those simplifications and I know that as we hear from tribal providers, how difficult it is keeping track of the different, even just there's 5 managed care plans, they all have different. And then if you have the QHPs and all the other ones, they all have different requirements for authorization. So I think it's great to see that. I think we saw some of that last year too. So this will really help us as we move forward with the simplification. Oh, sorry, Mohammed, go ahead.
Well, just one quick question. About the mergers of healthcare providers. If they are free to basically join forces, and it is something that could derail this work that we've done once we've finally accomplished universal healthcare for Washingtonians. That would make this whole exercise not really important unless we can have, especially around patients patient advocacy. If we cannot deliver that sort of protection for the patients from these mergers, the whole universal healthcare might not even work for ordinary people. So in terms of the AG's office, what guarantees do everyday Washingtonians have that they will be protected from something like that? Does that make sense?
Yeah, it does. I mean, so one thing I can say is the AG's office has done some antitrust enforcement against healthcare providers where they think the consolidation is so extreme that consumers aren't accessing services at affordable rates or their choices are being limited too much. The merger and acquisition bill would put even more oversight over those kinds of activities without having to neatly fit into sort of federal antitrust paradigms. But really, Mohammed, to your point, I think that our system is already pretty consolidated, right? We already have 6 big hospital systems in the state of Washington, the vast majority of whom employ physicians. They have home care agencies, they own ambulatory surgical centers, they own imaging. And so my thought in terms of the work that we're doing, and it's like the comment that I made to Pam about how we think about Medicaid rates, everything is in the context of acknowledging how consolidated the system already is. How do you take that consolidation and have it work for people rather than driving up costs for people, right? It's just sort of, here's where we are. And it's like Vicky said, sometimes I'd like to deconstruct the whole thing and roll back the clock. But in the absence of the ability to do that, it's how do you design a system around it? Which might not be the answer that you were looking for, but it's kind of sort of the reality that we have.
And I think the legislature is really.
Thank you, Jane. Thank you.
I think thank you for that question, Mohammed. But I think the legislator is really keen on trying to figure out like the sweet spot where there's access, but we don't drive providers out of the market. So those are both very important, and I think it's difficult. So thank you, Jane. Any other questions for Jane? Okay, Joan was unable to make it here, but she sent, I think, Laura Kate in her place to give the Washington Health Benefit Exchange update. Laura, I think you were just promoted to presenter or to.
Hi, thank you.
Thank you.
Good afternoon, everyone. I'm Laura Kate Zeichkin. My pronouns are she, her, and I am here on behalf of Joan for the Washington Health Benefit Exchange. Our update really is exciting in that we at the exchange saw a record number of enrollments through Health Plan Finder this year. Our open enrollment closed just about 2 weeks ago, and we have 273,000 Washingtonians in qualified health plans at the end of OE. That includes nearly 52,000 new customers, which is a 40% increase in new customers from last year. And some of those new customers include those who newly are eligible for qualified health plans through the state's 1332 waiver. That increases, or excuse me, adds eligibility for all Washingtonians regardless of immigration status. So we had about 2,200 customers who newly accessed QHPs through that avenue. And then we continued to see those who are transitioning from Medicaid enrollment to QHP enrollment as part of those new customers as well. So really demonstrating what access and affordability initiatives can do when it comes to coverage and access to coverage and care for Washingtonians. I'll also note that as others have said, it is legislative session. The exchange is largely focused on funding requests to sustain those really important access and enrollment expansions that I just noted. In particular, in addition to supporting continuous coverage and new populations, the exchange is focused on continuing to sustain the state subsidy that's now in its second year. And that as of the close of open enrollment, about 94,000 exchange customers who are below 250% of the federal poverty level are accessing. We are also really focused on all of the affordability bills that Jane and Dave and others have discussed. Really, subsidies are very important to accessing coverage. And we also need to recognize that subsidies are not a primary sustainable affordability mechanism, and those underlying costs of care must be addressed to ensure access and affordability for Washingtonians. Finally, we're really focused on supporting a policy to simplify plan choice on the exchange. There's a bill that was introduced this session to create a simpler shopping experience for customers to access standardized health benefit plans that really create more informed consumer choice to access QHPs that are high quality, low cost, and allow customers to maximize any available federal and state subsidies. So we're really focusing on that because we do know that we have many plans on the exchange. And when customers or consumers are overwhelmed by plan choice, they sometimes don't choose a plan at all and stay uninsured, or they choose a plan that's not the best for their and their family's financial well-being or their health outcomes. So that's our, I think those are our highlights for the commission, and happy to answer any questions.
Thank you, Laura. Thanks for joining us. Any questions for Laura? All right. Mohammed?
Oh, thank you, Laura. Can I ask, it might not be related, a quick question. We've been hearing from a lot of communities that who qualified for Medicaid because of the pandemic, those benefits were rolled back. The increase to the access of the Washington Health Exchange, might that be a reason, or because the complaint from the community, the concern from communities is it might be a bit more harder to qualify for Medicaid, which provided like excellent healthcare for them. Even though they're low income, how much they make as a couple or as a family might impact the quality of coverage they get.
I can potentially address part of your question, and then I'll look to my HCA colleagues as well. So I think at least part of your question really maybe speaks to the end of the public health emergency. And starting in April, those who have been on Medicaid since 2020, their eligibility has been redetermined. And the exchange in partnership with the healthcare authority and health plans and community members have really been working to ensure continuous coverage for those who are no longer eligible for Medicaid coverage and are eligible for qualified health plan coverage. So that is a major driver of the increase in qualified health plan enrollment that we've seen since April, and including during this last open enrollment period. So 41,000 customers who lost Medicaid coverage now have a qualified health plan. And again, kind of speaking to those subsidies and the access and affordability matrix here, 95% of those customers who have a QHP after losing Medicaid access, they're receiving state and federal subsidies to lower their monthly premiums. I hope that answers part of your question, at least.
It does. Thank you very much.
And I'll just refine one thing, Laura. Laura Kate, the way you described it made it sound like the PHE unwind work is completely done. It's a monthly rolling process that started last spring, and there's still several months to go. So that's just a quick clarification.
Yeah, thank you.
Thank you. Any other questions for Laura? All right, thank you so much, Laura. Good to see you. And Megan, do you have anything to add for state agency report out?
Not anything related to this work. Yeah.
Well, equity is important to this work.
Well, not any.
Anything
We're not driving legislation this year. And the legislation that we're reporting out on is the Economic Security for All legislation. That is 2320, I think it was, and then digital equity, 2313. So we have provided testimony on those bills. And those are bills with Employment Security Department and Commerce in partnership with those agencies and some other agencies. So, yeah.
Thank you. I've been following those too. And Laura just put some information about the open enrollment report in the chat box. And we have because we expanded our meeting an extra hour, we've got a 5-minute break right now for everybody. So it is 3:26 and we will be back at 3:31. Does that sound okay? See y'all in 5 minutes. All right. Are people coming back? Okay, is everybody coming back from the break? You guys good in the healthcare authority room? Okay.
We are all set. Thank you.
All right. So, sorry, I swallowed my water wrong. I just want to welcome everybody back. So next we have David Cutler and Nikhil Sani. Sorry if I got that wrong. Will present on administrative simplification overview. And then we'll hear from Dr. Christopher Chen from the Healthcare Authority, and he'll discuss some of the administrative simplification efforts for Washington State Medicaid. Sorry.
Wonderful. Thank you, Vicki. Hopefully you get some water. I will share my screen. Great, thank you. Just give me one moment. And as I'm doing that, hello everyone, I'm Nikhil Sani. I am a fellow with Professor Cutler in the Harvard Economics Department. I'm also a partner at McKinsey & Company, and also run at McKinsey the Center for U.S. Healthcare Improvement. Professor Cutler, do you want to do a quick introduction as well?
Sure, it's great to see everyone. My name is David Cutler. I'm a professor of economics at Harvard. Probably somewhat related is some of you may know Massachusetts has a health policy commission, which is a little bit similar to the kinds of things you're doing. And so I'm one of the commissioners of the health policy commission there. And so I kind of understand some of what you're feeling as you struggle with these issues.
And Professor Cutler, do you want to start with maybe this page and you know, what our overall research was?
Yeah, let me start off just like at a high level, which is like, all you have to have done is like ever try to use medical care to realize what an incredible administrative hassle it is. So like, there's not a single human being that can't tell you chapter and verse about how awful it is. And in terms of academics, there's been a long history of sort of people estimating the costs, trying to estimate the costs of administrative burden in healthcare. And so, and I've done some of that over time, and many others have done a lot on that over time. And so we know those costs are very high. What has not really been what has not really been studied very well is like, what could you do that could actually reduce those costs? So we understand things like, if the US healthcare system were more like the Canadian healthcare system, administrative costs would be lower. Okay, but it's not there. And if the US healthcare system were more like the French or the Swiss system or whatever, it would have lower administrative costs. Okay, but that's not there. The question that hasn't really been answered very well is, what could you do given where we are to make a material impact on the burden of administrative costs in healthcare? So I've sort of been pondering those, as I said, it's sort of periodically come to me over the years. And Nikhil and I have been working together for a long, long time. And so we'd also been talking about those. And I said, you know, I said to him, or he said to me, I can't even remember how it happened at this point. I said, wouldn't it be good if we could kind of combine like an economic view of like the overall size of the problem and so on with what McKinsey does extremely well, which is to go in and say, okay, how would you actually operationally do something? And so our goal here is basically to say, not like what would be the benefits if the US were Canada, because we're not, and whether that is a good or a bad idea, we're not going to be there anytime soon, but what could we actually do now? And so that's what we thought we would talk to you about, is what could we actually do in light of where we are? Not that that's the only thing, but just that seems like a relevant thing. Before diving in, I'll just give you one thing, which is what this slide is showing, which is we sometimes think about, oh, administrative cost is just one thing. Like, you know, a couple of decades ago, it was just have a common form, you know, common claims form. And so we actually did that. There is now a common claims form. And then what happened was every payer said, great, there's a common claims form. Oh, by the way, I have a supplemental form that I want you to fill out too. And so, you know, it's kind of like, it didn't do much of anything. So one of the things that sort of occurred to us as we went through this is there's not just one action. And that makes it, that in part explains, of course, why we haven't done very much, is because it's not just one thing. And it makes it much more challenging, but it also makes it, I think, much more plausible to then really dive in. And Nikhil will tell you about the really dive in to say, okay, what can we actually do? And the good part is that even though it's not just one thing to do, there are a number of things that we actually know how to do that will reduce the administrative burden. So that's maybe just a setup to, okay, what is it that is involved in that?
Great. And Professor Scudder, maybe I'll set up the key findings and you should chime in, then we'll kind of walk through. So getting you the punchline first. We estimated in 2019, when we scaled everything up, $950 billion in administrative spending. We identified 265 billion off actual interventions. And so our definition of an intervention was something that could be done in the next 3 years without affecting outcomes, quality, clinical outcomes, so on, using today's technology, as you see here. 265. What was very interesting to us is 175 of that could be driven by individual organizations. So you'll see some taxonomy we use where we defined interventions into within, meaning you can do it within your organization without external stakeholder involvement. Between, I need to at least have one payer and private payer and one hospital come together to deal with a PA process. It can't really do that one-sided. Or the third bucket we called was seismic. That would be something that required regulatory change, a centralized claims clearinghouse, and so on. So that 175 represents that within plus between bucket. 30 actionable interventions, and we'll show you the list shortly. But as Professor Cutler said, we've known this problem for a very long time, and frankly, these interventions aren't going to look like rocket science when we show them. It just requires sustained effort. There is no single big bang. This is chipping away at the problem over time, whether it's internally, externally, or jointly. So with that, I'm going to take about 5 minutes to set up a few basic facts. Professor Cutler already hit on this. We already know about this. Previous estimates when they looked at other countries and so on, say roughly 40% of this could be unnecessary or wasteful. What did we do? Took the 2019 3.8 trillion national health expenditures. We said we want to be very black and white here. Administrative spending is all activities in support of the delivery of care. Sometimes there's a gray space. So for example, the nurse manager on a floor that's both providing patient care, but also doing administrative duties of managing the department, we excluded that. So there could be actually more upside when you put in all the gray space of administrative spending. We went, let's just go really what's black and white and clearly in that administrative bucket. So 25% our estimate. This is based off actually P&Ls and estimating this for hospitals, for physician groups, and private payers. We have those three. And then we scaled it for public payers and other sites of care. When you break down that roughly 1 trillion, the 950 billion, this is where the administrative spending is across those 5 stakeholders. And you'll find here that nearly 2/3 is in private payers, hospitals, and physician groups. That was the center of our analysis. We focused on interventions for those 3 areas. I'll just note other sites of care could be such things as dental, home health, and so on. There's a lot of variability in that bucket. So that was one of the reasons when you actually break it up, it's pretty small. And then public payers, the way we scaled it, we took our private payer analyses and said, there's some things public payers don't do, and there's some things they do equivalent to private payers. So I think we put a haircut on it. If I remember right, it's about 50%, but all documented in the analysis. This was the key crux of what Professor Cutler was saying. Instead of doing the traditional, okay, administrative spending, IT, finance, HR, we took the actual P&Ls and turned them 90 degrees based on our operational experience across McKinsey and across academia and industry. We found we could group most administrative processes into 5 areas. The first we call the financial transactions ecosystem. That's everything associated with claims and prior auth and utilization management. Second, in the top right, customer and patient services. That's your usual call centers and moving self-service digital tools. The middle here is the administrative clinical support functions. These are the pure admin nurses. This is case management, those types of activities that have clinicians working in administrative functions fully. The bottom left here, industry-specific operational functions. These are your things that are unique to healthcare, underwriting, enrollment, but are in themselves operational or corporate functions. And the bottom right, industry-agnostic corporate functions. Finance, HR, IT, accounts receivable, resume screening, things that you have to do in any organization, including a healthcare organization, but are not special to healthcare. We were a bit surprised at how big the industry agnostic corporate functions were across our three stakeholders. This just shows you the diagram and especially the shares. And when you think about why are the shares bigger for hospitals and physician groups, it has a lot to do with economies of scale. There are about 350-ish private payers, plus or minus, in the US. There are 6,000 hospitals representing 2,500-ish health systems. And there are hundreds of thousands of physician groups. And if you kind of limit yourself just to the +5, you still are above 10,000 physician groups in the US. So when you have such a long tail and you think about economies of scale, it is hard to get those same efficiencies that some of the private payers can get, and frankly, a lot of non-healthcare industries can get. And so when we then thought about the within and between bucket that I mentioned, it's not that people don't know what the best practice is, or it's not that those best practices haven't been proven. It's about how do we scale those to the long tail to provide them with the same opportunities. And that's a lot of what those dollars represent, is taking what we know and passing it along, not necessarily trying to invent something new. So this is the breakdown between within, between, and seismic. I'm going to turn to the within and between, but Professor Cutler and I both hate hearing our voices. So I'm going to pause there just on the setup of the breakdown of administrative spending nationally and see if there are any questions. All right. And please interrupt us or put questions in the chat. I'm very happy to take those. So Professor Cutler, I will walk through the within between, and then I'll turn to Professor Cutler to maybe talk a little bit about the seismic. So where are the savings in the within between? So on the left, if we take that within between 210, that's the 175, if I go back a page, for the within, plus the 35 billion for between. You'll see that it's kind of spread across everyone on the left there. And a lot of it, as I mentioned, is in the industry agnostic corporate functions. It's just making resume screening more efficient, or accounts payable. I should mention the dollars here represent net savings. So if you are to implement a solution, we're not talking about, oh, you could reduce your cost by, make it up, $5 million. And forget that it might cost you $3 million in additional expenses to do it. That's a net of 2. So this all would be representing that 2 million. I'll also flag, we mentioned this earlier in the document, there are one-time costs to investing in this, usually 0.7 to 1.0 times your annual run rate savings. So if your run rate savings is going to be $2 million, expect that first year will cost you $2 million in one-time cost. And then you start seeing those 2 million in perpetuity after that. That's what these dollars, the 210 billion, represent, those net savings over the extended period of time. What do we see as the barriers or 4 keys to really making this happen? And we frame this in the positive for this discussion. Making administrative simplification a strategic priority. I am sure you talk to hospitals, private payers, amongst ourselves here. We all know this is a problem. But part of it is it's never a top 3 priority many times for organizations. And if it's not in the top 3 mindset for the CEO and the COO and the CFO, the sustained effort just is not there. And there's always something else. There's always a bigger prize. And that's a real reason that administrative simplification continues to remain as large in terms of size when analyses suggest there is dollars to be saved. The second is committing to transformational change. This isn't about just going in, doing one thing, and stepping back. As Professor Cutler said, this is multiple rocks that you might need to build a bridge. It's a lot of different things. And it's not just about the actual intervention. It's a lot about the change management that comes with it. So let's say you put in place resume screening. How do you then make sure the process evolves in how HR is functioning to incorporate automated resume screening versus just giving them the tool and then walking away? That change management, the cultural change part, is sometimes forgotten and is just as important as the intervention itself. The third is actually engaging the broader partnership ecosystem. This is a big difference today from 10 years ago. The evolution of what we might call the vendor ecosystem has been tremendous. The VC money that's flown in, the private equity dollars to build not just the agnostic companies I've been speaking about, but healthcare specific institutions that can come and take over claims management and you provide them a subscription. You need to tap that, because trying to do that, and the part of the reason we have this long tail is because each institution might be trying to do it themselves. And that's a lot of excess cost in the system versus taking advantage of someone else who's come up with a solution and bringing that in. And then allocating resources disproportionately. It's very easy to say, oh, you know, I'm going to take that excess capital there because I need it over here. You have to truly fully invest in this and really go in a disproportionate way and overinvest to make sure those savings aren't just implemented, but then fully realized over time as well. Last thing I will hit on here on the within between, you know, these are the stakeholders. This is driven by individual organizations as they're the ones who need to implement this. There are roles others have to play, but this is the list. And these are actual case studies of actual interventions tried at private payers and hospitals. And each of these was in our work quantified, and then we added it up on the net savings based off actual results. And that's how we have come up with that 175 and 35 billion. You can argue some of these might be within, some of these might be between. The key you should take away from this is if you believe this general list of items, these are things that don't require necessarily regulatory change. These are things that organizations can do themselves. Are there incentives that could be put in place to help these things perpetuate in the landscape? Absolutely, right? Those are things to consider as well. Because if we know it's not a top 3 priority and so on, how might you incentivize people to act against these? But also, none of these are rocket science on the list here, or some may be more complex than others, but many of these you read and you're like, yes, 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 we know that, and they just haven't happened. So I'm going to pause there. Go ahead, Vicky.
What is gold carding?
Gold carding is something that's been tried in prior auth, where you take certain physicians that are
like
from the
centers of
results.
excellence or something.
Yeah, you see them, they generally are very good and they hit the numbers and they're only asking. And then you say, look, we'll remove the PA burden from you because you're gold carded on these specific medical policies. And you can just go ahead and get greenlit earlier. So you remove the admin burden.
Thank you.
Jane?
So tell me if I'm asking this question too early in your presentation, but this is great. And the question is, where are the incentives and disincentives in the current system that result in this not happening? Like, it's just not a priority for the C-suite? And where are carrots and sticks that can be used to try to have some of this stuff be done?
I'll let Professor Culler answer that as an economist and a policymaker.
So Jane, I think that's like the $1 million question. I'll say a couple of things about it. I think there are 2 broad classes of theories. One, which is more on the sort of economics line, is that it's a matter of getting the incentives right to do it. So in particular, organizations, the more you move to kind of global payment for organizations, the more they're interested in cutting out the costs. And then cutting out those costs involves reducing the administration. And the problem with the system now is that there's not, the incentives to do that are sort of weak because, you know, you get paid for each thing that you do. So figuring out how to bill more for each thing is worth it and stuff like that. That's not a complete answer because there still are things like in the back office that can be saved, but that's part of the answer, is to sort of ramp up the payment incentives. The other version of the answer to what do you need to make it happen is that the organizations themselves are not thinking about it as a high priority. It's always a priority, but not a high priority. And one of the things that Nikhil and I have noticed as we've presented this to various groups, including COOs, CFOs, CEOs, fill in the blank O's, when we present it to them, many of them say, yeah, I kind of knew that like there was stuff here, there was gunk here, but A, I didn't know how big it was. And B, I didn't really, like, there's no like actual solution that I know really is going to work. And so it's sort of getting them over the hump. Whereas, you know, I know that if I pay for more people to upcode, I can upcode. I know that if I replace my CT scanner, I can get this billing. I know if I do this, this is going to happen. So part of it is, I think that there hasn't been a sense of like, no, these really, like there is a strategy here. It can work. I know if I just do it, I will get this outcome at the end of the day.
And Jane, did that answer your question?
Yeah, and I guess I mean, and Chris will know this, right? I mean, everybody's been struggling to create incentives to global payment, right? To taking upside and downside risk. And that's like, right, pushing a rock up a mountain. And I totally get it when you say you present the information for people and they see how big an issue it is. But is there a role for purchasers? Is there a role for regulators to sort of say, yeah, this is a priority for us, so you're going to do it? What do you think about that?
So I'll start off, and then Nikhil can answer. As a sort of partial regulator that is a Health Policy Commission member, we are trying to push these in Massachusetts. And we're hoping that not just this study, but that things like this combined with other actions the state can take can really try to move the needle here. So part of what Nikhil and I are doing in our ongoing work is to try and demonstrate that, you know, you really can do it and there's a toolbox here that can work. But it's also, but I think as a regulator, you can also have a big impact on it in terms of, and it's particularly in terms of things like the sort of third bucket, the sort of seismic activities that really require everyone to be on the same system to achieve the savings for. And that's where you really need the regulators to come in. So we have thought a lot in Massachusetts about how we could overall streamline prior authorization, how we could overall streamline information flows so that it's not people Xeroxing and faxing and entering and so on, but it's all automated, how we could streamline billing and payment through kind of centralized clearinghouses so that basically there is only one rule of the road, and that rule of the road is, you know, everyone defaults to the thing. Just to give you a sense of, just one more sentence on that. One way to think about billing, and sort of one analogy to it is, you know, when you go into any supermarket or any store, there are the universal product codes, the UPC barcodes. And all the stores have agreed to adopt them because it just makes their life so much simpler. In healthcare, we basically have the equivalent of every payer requires a different UPC code. And so every provider has to customize their product, you know, for each payer, you know, putting on a different UPC code for each one and so on. And then we complain, gosh, they're spending a lot of money doing this. And of course, they're spending a lot of money doing this because we haven't gone through and said, no, this is what it's going to take to standardize it. So for some of these things, we're going to have to do external standardization, I think. For others of these, it's hopefully just really demonstrating the proposition and saying to folks, look, you need to do this because we can't afford to continue doing what we are doing. And this is a better way to reduce costs than to cut your doctor's pay, cut your reimbursement for elective surgery, cut whatever else you're trying to do.
Yeah, I might, Jane, invert the focus. Smaller organizations might not even have the time or the bandwidth to go and ask about what else is out there, right? Take your local community hospital or your rural hospital in the state of Washington. Yeah, I'm sure they know they could do resume screening or accounts payable automation and all this, but they just don't have the way to get there. So how can you help them get access to those vendors or simplify the process for them to even access those vendors, because we know a lot of them, who they are, who are successful. Like, that's one way that we had talked about in the paper. Like, how do you get them the information? Because sometimes there's a little bit of information asymmetry here. I think the second thing I might add is another paper we might get to. We tried to quantify what is the average cost of a claim in the US healthcare system. And it's about $10 to $15 all in to process the 9 billion claims in the US healthcare system across private payers and providers. And we can break that. That's about $2 to $3 for a private payer, $7 to $10 for a provider on average. And there's some complex, simply you put all that aside. Credit cards, or sorry, transfer of payments, cash, checking, all that stuff. That's cents, right? If we need to process something from our bank. So what should that target be, right? What 10 to 15 probably feels high. I think we all would say it's high. But if you were to think about what's the outcome we want to achieve and how do we get there over time, that's another way that we've talked about in other work that could drive. Like, what are you trying to solve for? And then have the ecosystem innovate and evolve around it versus trying to say, this is the answer. Here's the outcome we want. Everyone's got to get there. How do we get there? And that doing that bottom up type analysis can help drive that way as well.
Thank you. Badisha has a question. I think Mohammed after her. Badisha?
Okay. So sorry if I'm asking this question too early into the presentation, but I kind of wanted to get your thoughts on, these are cost savings by organizations and health systems, and how to what extent would that translate into lower prices for consumers and patients? I mean, we are looking from the producer's point of view. We do not have perfect competition. And just because costs lower doesn't mean without perfect competition that the prices will go down. So I kind of just wanted to hear your views on that next stage.
Professor Cullen.
Yeah, so Badisha, that's a great comment, because if the firm is basically a monopoly, it'll just take cost savings and say, thank you, I'll make more money and I'm not going to pass it on. There's no guarantee about anything, and my sense is that requires some policy involvement. Sometimes it will come because insurers combined with state governments, for example, can go and say, look, we can do things that can reduce your administrative costs in a typical provider system. Maybe it's 20 or 25%, of spending. We can reduce that to 10 to 15%. And here's what we want. We want, therefore, to lower your payments, not by the full amount, but maybe you keep some of it and we get some and we pass those savings along. By the way, the passing along to consumers is also, from insurers, is also a big deal. My sense is that some of it will have to come from oversight organizations, things like departments of insurance on the insurance end, to make sure that savings they realize are passed along, and or departments of health and human services to make sure that savings there are passed along. And I also think that many big businesses, it's good to have them involved, in part because as they know what's going on, they can say, okay, look, we know you're doing this administrative savings and that'll save you money. And we want to make sure that those monies are passed back to us in the form of lower premiums. So I don't think it's automatic. And I think that one has to pay attention to that to make sure that the savings go to consumers.
Does that answer your question, Badisha?
Yeah, no, I mean, it does. I mean, I totally understand that oversight would be important because we are talking about a combination of private and public producers, which also means, introducing new policies and maybe new organizations, which has its own cost. So it's, I mean, no, it answers my question. I just think it's pretty complicated. Like what's theory is not necessary. It's not very easy to just be translated into practice in the real world.
Right. Thank you. Mohammed?
Thank you. No, actually, Jane asked my question. So.
All right, thank you. I had a question. How does this work with Medicare and Medicaid then? Because they kind of have their own systems and requirements. The idea of having a unified system.
I'll start off and then Nikhil can jump in. The Medicare and Medicaid, I think in order to get the biggest savings, it's really going to have to be everyone doing the same sorts of things. So, you know, if you're going to say we want all billing to use a common set of things, or we want prior authorization codes to use prior authorization to look a certain way, that's got to apply to traditional Medicare on the billing side, to Medicare Advantage on the prior authorization side, to Medicaid managed care plans. So there's so it doesn't work to just do, you know, take three big players in the market, Medicare, Medicaid, and commercial, and say, let's do something for one and not for the others. And that sort of creates, you know, that's a little bit like the symphony where the violins are playing one thing and the oboe is playing something else, and the, you know, cello is doing a third thing, where they may all be playing great, but it's just not going to be anything you want to see or listen to. So it's going to have to be that way. So in Medicaid, of course, it's less of an issue because that's more state run. My sense is at the federal level, you know, I've sort of spoken to people there, and there's a lot of interest in thinking about things that would reduce administrative burdens at the federal level. And I've met with a number of folks in the administration and Congress and so on who would, I think, be receptive to things that would be joint across different payers. I'm not, you know, there hasn't been a specific ask of anyone, but I see it as an issue that has to be addressed, but not one that's insurmountable.
I just had one more point. Let me see if I can, here we go. Which is when we looked at actually the savings, you know, for this bucket of within between, the government only represents 15 billion of it. So much of it is in the physician groups, the providers, the hospitals, and the private payers. And it goes back to this fragmentation point of the economies of scale on that long tail versus, you know, those institutions. Yes, there is an opportunity for them, but it's not as big because they do have some economies of scale. They're probably putting in place some of these administrative processes and efficiencies. So do need to tackle them, but a lot of the dollar sits outside of them.
Thank you. Any other questions? I think you have more slides, right?
We do, but I also know we're at time, so I want to be respectful
Keep
of that.
going. No, we can cut at the end. This is good.
So Professor, do you want to talk a little bit about the seismic? I can set it up, which is, we talked about 3 seismic areas: technology platforms, operational alignment, payment design, and these were the 7. But Professor Cutler, if you want to hit a little bit on this page and your thoughts.
Yeah, so just a little bit here. So in other industries, what's tended to happen, particularly when things like have to be standardized across lots of different players, is either the government has done it or one big firm or several big firms coming together acting like the government basically have sort of mandated it. So one example, which we talk about here, is I told you about the universal product codes, and you can see that here. But actually, let me just think about the first one for a second, which is the clearinghouse. If you know, on your phone, you can get money to transfer. You know, you can pay me, you can pay Nikhil, I could pay you, you know, sort of. And if you say, well, how does that happen? Like, how is that easier than in healthcare? The answer to how it's easier is that the Federal Reserve has said, like, if you want to be a bank and transfer money electronically, this is how you must do it. So you can decide to be a bank off the grid. That's totally fine. Nobody wants to bank with a bank off the grid, but you can decide to be a bank off the grid. But if you want to be on the grid, these are the rules that you will play by. You will submit the following information with the following fields in the following way, and this is all you will submit, and you're not going to ask for a supplemental submission form and all the rest of it. And so, and you could, and part of the problem with billing in healthcare is that, you know, every payer has their own thing and their own form and their own way of doing it. And, you know, some insurers, you know, at least the analogy in Massachusetts is, you know, some insurers, Massachusetts is capital M, capital A, and some it's capital M, lowercase a, and some it's 22, which is the official postal code for Massachusetts, and some it's, you know, you know, and like sometimes like out here we have zip codes that start with 0, so sometimes the zip code starts with 0 and sometimes the zip code doesn't start with 0 and stuff. So all of that stuff is so heterogeneous that everyone spends, just fortunes of money doing that and complying with that. And so what you'd want to do there is you'd want to say, okay, look, we're just going to have one payments clearinghouse, and here's the way it's going to work. There are rules for how you submit things. There are rules for what happens on the other end and stuff like that. And then we'll just transfer the information, and we already have a way to transfer the money. That's what's here. But this is how the world is going to work. And you if you want to play, that's the way you go about playing. In most industries, people are very, very happy with that. There's no competition in banking in terms of, oh, I require different information to submit for an electronic transfer than the other bank. They may say our website is better, or we'll give you more notification on your end, but it's not about how you go about transmitting, because that's always the same for all the different banks. And so in health insurance, the insurers will tell you sometimes that that's a competitive advantage, but really it's not. It's just a way of kind of saying, I don't want to have to standardize to what other folks do. I don't want to have to spend money for that. But if everyone's going to do it, then you just say, look, we're just not going to compete over what does your claim form look like versus the other person's claim form. We're going to compete over other stuff. And so that's a feature of a lot of these things here, which is that they're designed to make it be standard so that you can literally just plug and play some aspects of it. And you compete over the other aspects. You compete over the customer service, and you compete over stuff, but not over like, how am I going to, what form, how do you write MA on the form, to send in for the reimbursement.
So basically, you're breaking down the institutional barriers and making it the same for everybody.
That's correct. And then you go to them and say, look, this is going to save folks a lot of money. We understand there's an upfront cost, but we know this is going to save folks a lot of money. Out here, our provider systems, there are literally entire buildings of people devoted just to billing. Like literally our biggest provider system has a whole new building it built a few years ago, entirely filled just with people who do billing. And you say, well, maybe after we're done with this, you'll be able to rent out the top 2 floors, for something else. You just won't need them anymore. And like, that would be a great thing if that happened.
You could house homeless people. Jane.
Really? So using a recent really concrete example, right? The feds just issued their final the interoperability rules, and they have standards for the API for prior auth transactions. And our legislature actually passed legislation last session when the rules were proposed, saying, okay, when these APIs, the federal APIs go into effect, fully insured commercial health plans, you're using it too. So I like to think that our legislature is like thinking about this stuff in order to make something like that really meaningful, right? Because remember, those rules apply to qualified health plans sold on the federal exchange, like Massachusetts, we're a state-based exchange. So, I mean, I love the fact that they did that. We're implementing that now in my agency. How do we get Boeing in Alaska and Microsoft to sort of say me too? Because that, unless you get the self-funded lives in, it's not I don't know that it's a big enough change to really make a massive difference. What do you think?
Nikhil, let me give that to you. And also you may just want to mention the part about like the cacophony of the prior auth stuff here as well.
Yeah. So look, maybe just on the prior auth space in general, when we looked at what's the average cost of a PA, it's about $40 to $50 all in across providers and private payers. Now, there are a lot fewer of them than the 9 billion claims nationally, but they are pretty costly. One thing we've come to learn about PAs, Professor Cutler and I are doing some research and going to publish more on it. It's kind of like when you're waiting for the subway train and there's a sign that tells you it's 5 minutes. If you ride the subway every once in a while, you don't notice if it says 5 and it shows up at 7. If you ride the subway every day and it's at 5 minutes and it shows up at 7, you're pretty upset. That's what it's like being a patient versus a provider. A patient, generally doesn't deal with PA on a regular basis. They deal with it, it's frustrating, but you actually look at their not approval rates, but how well they thought the process satisfaction rates, they're generally higher than providers. Where providers who are dealing with this on a regular clip, clinicians, both physicians and nurses, they're the ones who ride the train every day, and when it's 7 minutes and off.
Nikhil, I think you got muted.
Yeah.
Sorry. Who are we trying to solve for, and what are we trying to fix for them? I think is really important. Because even when you think about the $40 to $50, yes, that could come down. 90% of that's roughly labor, but the clinician's time can't come down because the clinician needs to review the paperwork and so on. Could we use things like Gen AI to gather that data and fill out the form the first time? Absolutely. And those where AI tools come in. The back office time, the admin time to go through 7 or 8 different systems and gather that, and that's non-clinical, but usually labor, that could definitely be optimized and looked at. So now, Jane, you asked about self-funded lives versus fully insured lives and how we think about that. Look, there's the trickiness is when you're trying to standardize this type of stuff, the trade-off is product innovation. And each company is creating their own insurance products to get their employees to select them sometimes, because it is part of the package. And so therefore they put in different PA rules and so on. There's over trying to remember, we looked across the nation and figured out how many different codes had PAs on it. And it's something like 4,000 or 5,000 different J codes and facilities and so on. But so much of that in our research showed are things that people forgot to turn PA off of. So a branded drug goes generic, someone forgot, and there's still a branded PA running out there and so on. And when you've got so many different PA medical polys associated with the same code, United has something different than Humana has something different than the local Blue. The provider doesn't actually check. If you think about it, like, do you really check every time, who the other person is on the other side? Like, you're like, look, if I got filled this form out, they just fill it out. And so they're filling out forms for payers that don't require them to fill out forms sometimes, but they're just like, it's faster than actually checking. And that's another overall cost we see in the system. And the last thing is some of these, frankly, in the industry, you talk to chief medical officers, they're non-controversial. Like, we know that the lab numbers for 10 years of this drug say, if it's this lab number, you give it, and if it's this, you don't. And so that medical policy should be standardized or could be standardized, and a lot of medical directors would agree with it. A new drug launch, though, you don't want to allow that same type of standardization because we don't have enough real world evidence. And this is where each payer's clinician group is making that judgment. Same thing with facilities. Like, we know sometimes it's safer to do something in an ASC versus an inpatient facility, but we don't need to have different versions. So if you were to do a count of all the different codes in the state of Washington that have PA, and then have a group come together and actually say, which one of these are just standardized, or which one of these should we remove? Hey, someone, forgot to take it off. Which one of these can we feel are pretty non-controversial and standardized? And then keep innovation on the right bucket. There is something there. And Jane, I think that's how you might tackle some of the self-funded lives, is because if you can pull some of that stuff out, then it just kind of becomes simple or standard and cleaner to tackle that portion of the population.
So I just put into the chat, I'm going to do this really quick, Vicki. I just put into the chat a report that we're required to produce annually. The carriers have to report to us the 10 most frequently requested codes for prior auth and what the approval rates are. And I can tell you that when somebody using that data, when somebody brought up, well, wait a minute, why the hell are we applying prior auth to these things, right? Because they're approved consistently 99% of the time. Major pushback from the payers, major. Okay, I'll stop.
Yeah, nobody has ever done like a good spring cleaning of the prior auth stuff. And it's just, some of the things, if you're going to be spending $70,000, it's worth spending $70 to make sure it's right. But if you're going to be spending $40, it makes no sense to spend $70 to make sure it's right. So, so there's some things that are legit, and then there's some things that are just like, why are you possibly doing this?
Mhm. Thank you. Dr. Chima, and then can we wrap up after that, or you guys have more? Okay, thank you, Dr. Chima.
Thanks. Thanks, David and Nikhil, for that well put together presentation. Just had a question about, so I really, think the seismic interventions, opportunities you outlined that does, definitely have much more potential for impact at scale, right, in system as against the individual and the between interventions in terms of the benefits that can accrue and at the scale at which they can accrue. But they seem to be more, again, just by their nature as well, the things that are more likely to be driven at the federal level, right? So the question is, for a state commission like ours, what are some opportunities that you see where states, agencies, or state commissions like ours could help accelerate some of that progress in seismic interventions that you listed?
Yeah, look, I'm happy to start, and then Professor Cutler, you should chime in. I think of seismic having two different types of effects. One is augmenting interventions for the within and between. And Professor Cutler's talked about, look, you're doing prior auth and all this stuff, but if there's regulation around prior auth, that could help standardize. The second is separate from augmentation is acceleration. So if we know there's a long tail of hospitals that aren't getting access to something, there are seismic interventions that can help you accelerate that group getting access, as I was mentioning before, to the same vendors and so on, and saving it. Augmentation sometimes, like you said, might be more of that federal type stuff, like, if you want to do clearinghouses and those types of things. But acceleration, that's something a state can do. How do you accelerate your hospitals getting access to something, or your private payers getting access to something? And another body of research Professor Cutler and I are starting is trying to understand hospital productivity and trying to break it down in a way that's not just cost efficiency, but it's cost, quality, and service throughput. And then you put those things together and you say, okay, what can I do to incentivize or help people understand they're good today, but this is what great looks like. And we're going to run regressions and say, this is what great's associated with. So these are the things you can do to actually do that. So that's a little bit of maybe how I think about the seismic is acceleration might be more in the wheelhouse for a state than augmentation. But go ahead, Professor.
No, I agree with that. I'll just add one thing, and I'm embarrassed I don't know more about Washington State. In Massachusetts, our biggest insurers are local. So we have Blue Cross Blue Shield of Massachusetts, and we have Point 32. We have some presence of United and Aetna and all of that, but not an enormous amount. That makes it easier to deal with some things because, they're not saying, wait, I don't understand. You want me to standardize something in Massachusetts, but then Montana is going to want me to standardize something else and so on. So that sort of gives, our discussions have a somewhat different tenor because we think that a lot of our discussions are really applying to organizations that are doing the vast bulk of their business in the state. And therefore we can, they're somewhat more receptive to maybe there's a state solution to these issues. I mean, the other thing, of course, in Massachusetts is that we pride ourselves on having a high rate of insurance coverage, which we've done various things about that. And then when you say, by the way, what is the thing that most puts that at risk? It's the rising cost of medical care. So we can bring people to the table with the sense of like this thing that we're very, very proud of. We used to be proud of the New England Patriots and now we're not. This thing that we're really proud of, like, is going to be in danger if we don't address this.
Thank you. Anything else? To thank Dr. Chin for being patient with us. We've got lots of time still. All right, thank you, Nikhil and Professor Cutler. We really appreciate, this has just been really great. I mean, and it really sets us up for what Dr. Chen's going to talk about. So thank you so much. We might have other groups for you to talk to.
We're happy to, even at 7:20 at night on a Friday night on the East Coast, we're delighted to join you.
Well, thank you. Right. Dr. Chen, thank you for being so patient.
Yeah, no, thank you. Thank you for having me. I guess, and I just want to check in really quickly on the time available for the presentation.
Well, we've been playing Let's Name That Tune or something back here, and Liz thinks she can do the last presentation. And how many minutes, Liz?
15
just
left.
15, so till 4:45, is that good?
Great, that's perfect.
Thank you.
Yeah, so thank you so much for having me today. This is certainly a topic that I hold near and dear to my heart as a physician, as a patient, as a government bureaucrat. I think administrative burden certainly is something that I feel really passionate about. I remember asking Jane once at a conference if working in health policy meant banging my head against the wall for the rest of my life. And she said, there's hope. And so I really appreciate the attention of commissions such as this one, homing in on topics like this, which can frankly be boring sometimes, which I think is one of the reasons why it is such a longstanding issue, but has not yet been addressed because it's hard to communicate effectively about administrative burden and what the potential underlying solutions are. And I think today I just want to share a little bit about how we think about administrative burden, and also kind of transparently, I did not realize that we were actually going to have Nikhil and David at the presentation. They are kind of luminaries in this field, and so some of this is a little bit of a repeat, and I'll try and skim over it. But I think to think about and talk a little bit about how we're thinking about things at the Healthcare Authority. None of what I'm saying is meant to be policy advocacy. I know that we have very prescribed channels of kind of advocating for certain policies and changes, especially since we're in the heat of session. But we are kind of thinking a lot about these problems, and so just want to share that. So thinking about administrative burden, you've heard a ton about this. The only thing I'll add to what Nikhil and David shared before was thinking about expanding the scope of administrative burden, not just to the providers and the payers that we work with, but also to the patients and the individuals that we serve. And thinking about even in how our patients access their benefits, and applying for assistance programs, accessing program benefits. And on the next slide here, I'll just talk a little bit more about the impact of administrative burden, which is a significant driver of costs. We all know this. Healthcare costs per capita are higher in the United States than anywhere else in the world. Part of the reason is our administrative costs per capita are also higher than anywhere else in the world. On the next slide, I have some impacts of the administrative burden. And we know that it's harmful to providers. In this study of 1,774 physicians, the more time you spent on administrative duties, you had more burnout, decreased career satisfaction. Even when folks try to turn these tasks downstream to other members of the clinical team, they end up getting burned out. So it's not like they can manage it better. And it's harmful to individuals. And speaking a little bit before when I was talking about the administrative burden on individuals, there's an interesting New York Times article that talked about how hard it is to be poor in this country. And that applying for practically every program that aids low-income people is harder than any program that benefits wealthy people. So if we think about kind of ways that people with jobs and with resources benefit from federal programs, it's often a tax credit, something that's just filed on their tax forms, versus a low-income aid program may require just hundreds of questions asking whether or not you're eligible. Despite the fact that mistakes in administrative mistakes are common across income levels. And so everyone forgets to open their mail, everyone forgets to pay a bill, and everyone misses meetings. I think I missed a meeting today. But that doesn't mean for people with resources that they lose their benefits. And so I think there's another real question here about administrative burden as a tool to perpetuate systemic racism and structural inequities. And so on the next slide, I have a little bit about why does administrative burden exist. We have a significant degree of fragmentation in US healthcare, and you heard this from Nikhil and David. Actually, a lot of this slide was pulled from their work. With significant regulatory complexity, just fragmentation, fragmentation, fragmentation. I think a lot of administrative burden is driven by good intentions. And we all want to improve quality. We all want to ensure safety. We all need to steward scarce resources. And administrative burden is often put up as a way to achieve those levers. And some degree is necessary, even in other countries that have a meaningful, other countries still have a meaningful degree. And so I showed you that slide before where the United States is an outlier in terms of the degree, but everyone still has some. And even, you know, the NHS or other countries with universal coverage have ways of measuring productivity. And however, much is unnecessary, as we know, and doesn't really drive inherent value to the system. So the question for us is always, what administrative burden that people think is necessary today can actually be unnecessary tomorrow. And, you know, we think about this as an agency sometimes, or oftentimes, is what do we want our MCOs competing on? What truly drives value? Like, is it of any value to have a different form? And probably not. And I think highlighting here a number of the policy proposals that David and Nikhil talked about. And on the right-hand side, these are things that we've certainly thought about before. The centralized claims clearinghouse, I would say this is not just a cost-saving mechanism. This is an equity issue as well. We experienced this through the pandemic. There were lots of ways that we could have equipped more types of providers to be vaccinating our clients, but like firefighters, like Medical Reserve Corps, but there was no way for them to be paid with insurance because billing and coding is incredibly complicated. So a claims clearinghouse could be a mechanism of lowering that barrier to entry for many provider types, which we know we want to do with folks like community health workers, like doulas, like peers. And so I also want to kind of put something as boring as a clearinghouse into the context of being a potential way to meet social determinants of health and increase the representation of our provider workforce. Also just kind of calling out that other states have done this. Ohio, interestingly, with their latest Medicaid managed care reprocurement, created a first in the country type entity called the fiscal intermediary. This is a single entry point for all claims and all prior authorizations. And I think it also handles credentialing, but I'm not sure, that will operate across their managed care organization. So it's not totally unprecedented for states to be acting in this way. Fully electronic prior authorization system. Jane referenced 1357 and the CMS interoperability and prior authorization final rule, something that we're definitely paying attention to, and I'll talk about that more. Harmonized quality reporting, standardization of provider directories. It is just drives me crazy that to this day, you know, we don't have standard information about which doctor is located at which address and what their hours of opening are and what their phone number is. That's just like basic information that other industries have already solved. So I'll just move on to the next slide. Initiatives and administrative burden reduction. I think I could have listed a number of things here, but I'll just start at the top. That alignment and oversight is core to who we are as an agency. It's what we're tasked with. I don't think anyone at the agency really says we would like to create administrative burden today. I think we are subject to lots of requirements and understand the complexity of our authorizing environment, whether it be the state or federal agencies, and we are subject not just to CMS, but also, as you guys know, to a number of other agencies, SAMHSA, HRSA, et cetera. And so I think really trying to operate in an environment like that and serve clients and do that across a number of programs and contracts. If there are ways to simplify, then I think the agency, I might suggest, is certainly interested in it. And we just often have to identify other conflicting requirements in this fragmented system. One initiative that I really want to highlight was the Washington State Action Plan for Removing Barriers to Health and Human Services. This has been a really exciting initiative that we've done in partnership with the HSS Coalition, with the Benefits Data Trust. We have a goal to get to a 20-minute application for clients to get SNAP, TANF, childcare, and Medicaid benefits. I think that is incredible. This is work that's being done with human-centered design. They've looked across those financial eligibility applications for 4 programs and identified over 1,300 questions that clients have to answer in order to access those benefits. Over 150 of which were actually duplicative. So the agency is working really hard to streamline application and access to benefits. And so just wanted to highlight that in terms of reducing administrative burden for the people that we serve. The Performance Measures Coordinating Committee is another one that I'll highlight. This was established by Substitute House Bill 2572, I think back in 2014, the goal was inherently to reduce variation in administrative burden and focus on key quality priorities. The PMCC created the first Washington State Common Measure Set. And that is a measure set of about 60 measures that we try to use across all of our programs. Quality is an evolving area, especially with interoperability capabilities that payers and providers are adopting. There are new ways to exchange meaningful clinical data that actually improve outcomes and not just measuring process measures through claims. And so this is something that the agency is engaging in conversations with CMS about how we shift to digital quality measures. We've also engaged in conversations with NCQA. And so I think that is an active area of interest. The multi-payer collaborative for primary care transformation, this was alluded to in Nikhil and David's presentation around moving towards value-based payment, capitated payment. It does offer flexibility above what is reimbursed fee for service, and we're trying to do so in a multi-payer way, which really kind of reduces administrative burden when people are able to serve a broader population under a common model, a common payment model, alternative payment model. So this is one that we're working with CMS on, and lots of folks are enrolling. We have interest across Medicare, commercial, and Medicaid, which I think is very exciting. The interoperability rules implementation. I just hired our first clinical informaticist in January. Her name is Brittany Rowlett. We're very excited for her to get started implementing 1357 and getting the MCOs on a prior authorization API. We've been trying to understand what those requirements are, what our existing capabilities are between payers and providers. We have some local innovators in the state between Regents and Multicare who are very active in the HL7 Da Vinci working group. And we're very fortunate to be able to draw upon that expertise. And so I really do think that Washington can be a leader among the country in terms of getting our healthcare ecosystem interoperable and communicating effectively. And then we're also participating in the administrative simplification program led by One Health Board, which I think is under the oversight of OIC. I meant to ask Jane before the presentation, but we're active participants there too, and think a lot of initiatives such as the ones that I mentioned could be driven through existing forums like that. So that is the presentation. Yeah, and happy to take any questions.
Thank you, Dr. Chin. That was, and thank you to the staff and the consultants for bringing these presentations together in the way they did. That was really helpful. So on the, I think it's called the universal application that the Health and Human Service Coalition is working on. People will go in and put in their information and then be told what programs they're eligible for.
That's my understanding, yes.
That's great. Does anybody have any questions for Dr. Chen?
I guess one comment that I do want to make is I think now the Office of the Insurance Commissioner, HCA for Medicaid and HCA for PEB and SEB, I think we're trying to like sing off the same sheet of music now more than I've experienced. And it is all with, it is all with the idea of people don't care about the fact that it's OIC that's doing one thing and HCA PEB said that's doing another and Medicaid that's doing another. And the other thing that we always think about is several of the Medicaid MCOs are also in the commercial market, are also offering benefits through PEB and SEB. So we are always, I think, on the lookout for opportunities to try to work across. And that's what I think the beauty of that new prior auth rule is those Medicaid MCOs have to comply. And Medicaid fee-for-service has to comply, although maybe with a little more flexibility. And the legislature said, okay, fully insured plans have to comply. So it's just how we take those opportunities where we see them. And I think where the Universal Healthcare Commission can help support that and, give us more oomph, we would welcome that.
I totally agree, Jane. I think and that was one of the slides that really stuck out to me from Nikhil's presentation was the one 4 keys to capturing this opportunity. It was a very basic slide, just had 4 pictures on it. But the first one was making administrative simplification a strategic priority. And I think that's, it's hard to do, as I mentioned before. It's hard to talk about and communicate effectively of, what is the value of a clearinghouse? I mean, people's eyes kind of glaze over. And there's lots of just like infrastructural components here. But I think if we're able to make it more of a strategic priority for ourselves, for the people that we work with, it's certainly being made a strategic priority by the federal government at this point, which really helps. Then I think we can make some meaningful progress.
Thank you. And the primary care transformation, is that the primary care certification of 3 levels, aligning payments across payers? You speak a little bit more about that, because I don't know if people really know about that, and I think that one's pretty big too.
Yeah, I think so the primary care transformation effort, which is led by our Chief Medical Officer, my supervisor, Judy Zerzanthul, has been a multi-year effort to support primary care and kind of give them the resources they need to take care of their population that they're accountable for under a more unified alternative payment model. And so, the premise of this is that primary care physicians are paid significantly less than specialists. One of the reasons is because cognitive work is kind of structurally undervalued in our fee-for-service reimbursement environment. We pay doctors to do stuff to people. We don't really pay them as much to talk to people. And primary care docs talk to people more than they just do stuff to people versus like surgeons or other proceduralists. And so they get paid less. And so in a fee-for-service reimbursement environment, it can, it just is harder to care for a broader population. And under alternative payment models, where you're able to pay primary care providers differently and give them more accountability for the entirety of a patient's kind of expenditures, then they have different incentives. So for example, if someone has back pain, maybe not just refer them straight away to an orthopedic surgeon who's more likely to do a lumbar fusion. But if you are paid under a PMPM, a per member per month arrangement, maybe you'll have more of an incentive and time to talk to the patient. Okay, well, are you doing your back exercises? Are you doing physical therapy? Maybe we don't have to jump straight to a surgery and we can try more conservative measures and have result in better outcomes. And so the problem for APMs has traditionally been providers may feel like they're too small to take on risk. Especially when you divide your patient population. Let's say you have a panel of 2,000 people. Dividing those among 18 different plans, it might be hard because you're operating on different arrangements. So this multi-payer initiative is really a way to try and get commercial Medicare and Medicaid together. And so an individual provider, providers don't really like to treat their patients differently across payers, right? Like they don't want to say, patient, you get this, commercial patient, you get this. So under a multi-payer initiative, we're able to achieve an alternative payment model where people have just greater ability to achieve impact and change for how they take care of people.
Thank you, Dr. Chen. Any other questions or comments?
I'll just add
And
that.
then the last.
Go ahead, sorry. I was just going to add the part where Dr. Chen said a lot of different pieces of this can make people's eyes glaze over, but it's really sometimes the simplest things that hold up a lot of things that the average member or citizen experiences. I can speak from my own standpoint in the PEB and SEB program work. It's not a secret that our accounting system is one of the oldest in the state. And if I asked you a pop quiz question, Chair Lowe, I'd say, how many days are there in a calendar year? Typically, you'd say 365, and it's not a trick question because it's a leap year. For my accounting system, it's 252. Weekends don't exist. 20 minutes from now is Monday. And so when we have to sequence things, it falls behind on the weekend because the weekend doesn't exist. Our accounting system takes weekends off too. So it's like simple things in systems that pervade our society, pervade healthcare, pervade payers and insurance that really can have profound impacts. So that's all I wanted to add.
Thank you. No, and I really appreciated the analogy with the UPC codes, or because I used to work at a grocery store as a checker when we still marked items and then when we went to scanner. So that's a huge difference. So, and then next month we'll be getting a presentation from One Healthport, right? And so that kind of segues into more of that administrative burden, lessening it. And so any other questions? We can go to Liz and get closer to wrapping up. This has been a long meeting, but it's been very fascinating. Thank you very much, Dr. Chin. That was really helpful.
Thanks for having me.
Thanks, Vicki. And thanks. I'll try to be very brief because I know it's Friday and people's brains are probably fried. That was just such a fascinating conversation, and I hope it's makes a lot of sense about why dealing with some of those administrative simplification efforts could really help pave the way for where we're trying to go, because they won't just go away. So really appreciated that. And I loved the grocery store analogy too. Just, it's like sticking in my mind. So we're going to totally turn back to the other task of the commission, which is the universal system design. And I just want to reorient folks to where we are, because we're going to be giving some, we need to give some direction to the FTAC on the next topic at hand. But just reminding everybody, we're doing a 3-phase process, and we are currently in phase 1. And things will hopefully speed up, and we'll start being able to do some more simultaneous work as we're getting into the next topic. Let's go to the next slide. So what does phase 1 involve? It involves eligibility, benefits and services, provider reimbursement and participation, which will then be used to start developing some cost estimates and then figuring out the financing. So that is the approach that we're taking. And if we can go to the next slide. Here's where we're at in terms of eligibility. So I think I think it's a given. This is the Universal Healthcare Commission. It means that everybody's covered. That's the assumption that we're talking about. When we've been talking about eligibility, it's really not about whether or not someone's in or out. It's mostly been focused on the financing. And I'm sorry if that hasn't been clear to folks, but I think we've just been going through these groups to really determine whether or not there's a way to access the financing for these groups of people as we're building our system. And here's where we're at. Over the last year for Medicare and ERISA plans, the commission with the input of FTAC has decided at this time, there's no pathway to access the financing associated with those programs and the folks that are covered by those sources of coverage because of the federal barriers. However, you all have agreed that the individuals that are getting covered by Medicare or ERISA plans should have access to the same benefits and services that may not be covered under their coverage that the universal system might offer. So in the meantime, the commission is focused on adding the opportunity for supplemental benefits once that benefits and services conversation has been had.
And Liz,
Go ahead.
Sorry. I just want to remind people about the presentation I gave, and sorry, Dr. Chima, I hope we can get you caught up. From the program that I ran at the tribe here, it was that we knew we couldn't get the funding for Medicare and Medicaid into our program, so we wrapped services around them and brought them up to the level. And until we can deal with that, that's kind of what we're looking at here, so we can stop being in the paralysis of analysis of what we're going to do here and get to the rest.
And then just really quick, Liz, I know this is really nitpicky, but any private group health plan is technically under ERISA. Every time we say ERISA, can we please say self-funded ERISA plans?
Yes. Okay.
Because the plans that we regulate, fully insured plans, are private group health plans. So because people confuse that all the time.
Okay.
And just if we can be clear on it, that would be lovely.
That's great, Jane. And there's actually a slide that I want to make sure that we have the right description and you can make sure that we're doing that right. So thank you. We will fix that slide. And so with Medicaid, the difference is, and thank you, Vicki, because I think your presentation really inspired a lot of, I think, the thinking and recommendations. That the commission agrees we should try to achieve parity and equity in terms of the benefits that folks are getting, no matter what their source of coverage. So with Medicaid, from the discussion that we just had, we recognize that there's a significant portion that's covered by Medicaid and that there are waiver opportunities to access the federal financing that comes with that, with Medicaid. The challenge is going to be ensuring a design that's going to allow the state to get those waivers because there are several requirements in order to obtain that money. And many of the conversations that we're going to be having during the rest of phase 1 will provide the details about what needs to be considered with Medicaid and how it will be addressed for applying for waivers or SPAs. So just kind of want to level set everyone on that piece. So that really goes to the next slide, which is it gives us actually, so we're turning to benefits and services, and then we'll go to the next slide. So that gives really the starting place. We can go to the next slide, Angela. Yep. And this is probably very familiar to Jane and other folks, and maybe some of the other folks on the line today. This is our starting place. As Jane said, you know, there are groups that we can't control. There's the red mark ones, and then there are ones that we can control. And those are the green starred ones. And so Jane, does that help here? Am I getting this right?
Yep.
Okay.
You're getting it right.
So what we're striving to do here is to look at trying to create benefits that start from the place of the green stars and figure out where do they align, where do they not align, and what needs to be filled in and what doesn't. And then for the red boxes, eventually we'll go back and try to circle them or supplement those benefit packages with whatever we decide based on the green stars. So that's the starting place. So if we want to go to the next slide, we had hoped to have a grid comparing benefits today, but which you all have asked for, and we have discovered that that does not exist. We're in the process of HCA staff and HMA are working and trying to put something together with some help from the OIC to be able to give the FTAC just a table that shows when you look at those 4 stars, those 4 buckets of coverage, what do their benefits currently look like? We know that generally Medicaid has a more generous benefit package in terms of being able to provide things like long-term services and supports, but there's a lot of variation. So we're working on that. So my question for all of you is, and in the last 10 minutes that we have, and I think we'll just say, if we can't get all these questions on the table now, we can have them sent in via email. What is the commission? What do you all need from FTAC to look at benefits? Some considerations, what are the priorities? What are the gold standards for what the benefit package might look like? What are some potential approaches? These are just some of our, starting questions, but really want to know from all of you, what do you need from FTAC? And I know there's another slide that has some of the requirements that are outlined in the legislation. This is one of the requirements. So I'll just stop there and appreciate your input and recommendations for FTAC.
So here's what I would say. I think that when we put that grid together, we are going to find when it comes to med-surg services, medical services, a ton of commonality across, I think. And now because of our state parity statute and federal parity, we're going to find a fair amount of consistency across. Medicaid has richer and more varied mental health services than in the commercial market. I think the biggest issues, right, are going to be the ones that we always confront: dental, vision, long-term care. But to me, and because there's going to be a significant amount of commonality across, I guess my question is, what really makes a difference in terms of the ability to access coverage for Medicaid as compared to, for example, PEB or SEB or a commercial health plan is out-of-pocket cost sharing. So I mean, clearly provider networks as well, we know that, but I'm trying to figure out where does the discussion about out-of-pocket cost sharing fit in terms of thinking about what the benefit design, because to me, benefit design is covered services and cost sharing. So that's my question.
Do you want Badisha to just, anybody have a response, or can we go to Badisha? Because I have a response. Go ahead, Badisha.
Okay. So I don't know if it's possible, but when you're creating the benefits grid, which is, like you said, is underway, is it possible to, within that grid, also put an average cost? So for each of the 4 green stars that you have, I'm guessing the benefits are based on, you're kind of trying to create the benefits for each of those 4 groups. Like, could we also see the cost? And I know the cost could be different if there are different type of insurers, but even to see an average cost would be useful, because I'm always thinking about benefit and cost, and then that could help us with the cost containment later.
That's a great suggestion.
The cost or the reimbursement, though, because the cost would be what the provider shoulders. The reimbursement sometimes isn't based on cost, like Medicaid.
Right. I guess, yeah, I mean, we could
the reimbursement.
Reimbursement. Yeah, I mean, there are different aspects of the cost. So reimbursement, and I don't know if it's possible to include what is the out-of-pocket share, things like that. But I would like to see some dollar value that I can compare.
So maybe the contracted amount, because that would include the cost sharing in it,
Yeah.
right?
Yeah.
That's a good, yeah. Anything else? I know that from the Universal Healthcare Work Group that we never established the cost sharing, like co-pays and deductibles.
Yeah.
That they help, that actually cause harm. I think there's some studies, and so I want to make sure that we consider those things. But I think what the cost sharing will end up being is how much of a premium maybe a person pays. Is that based on income and family size, or like the QHPs? Is that what you're thinking, Jane?
Actually, I'm thinking deductible, point of service cost sharing. Clearly, what's affordable in terms of percentage of a premium that somebody can pay is definitely important. But what somebody has to pull out of their pocket before they ever get their health plan to pay for a service.
Right. And what is what is the purpose for that in this conversation about universal healthcare? I guess, do copays and deductibles actually serve a purpose, or do they continue to make it inequitable for people who have lower incomes?
I mean, clearly
I'm really against it, if you can't tell.
Yeah, no, and I'm not arguing for it.
In the Indian healthcare delivery system, we don't have copays, and we don't have any problems with people overusing services or any of those myths. So I really do, from my perspective, I've seen the last 27 years, I don't see a purpose for them other than to keep people who have lower incomes from using services and taking resources away from people who
Yeah,
think that
I'm,
they're
Vicky, I'm not in any
gonna
way,
not get what they want.
yeah, I'm not in any way
No, I'm not
advocating
trying to argue with you
for
either.
deductibles, or it's just, right, it's an elephant in the room. And how do we think about it?
Yes. And Gary, I know you worked on the ACA, so
So
should have something.
I think you're making a really good point, right? So historically, the rationale behind deductibles and copays has been, well, you have to give people, quote, skin in the game, or they're going to, use too much healthcare. And I'm not sure if anybody really believes that anymore. What's happened now, increasingly, both on the employer side and certainly with the exchange, is that higher deductibles and copays have made it possible to charge lower premiums. And we tend to look at premiums as our measure for how affordable healthcare is, when we should be looking at the total cost that people have to bear to get their healthcare. And
Isn't
really,
that what the ACA used, all of it? Like the cost sharing and the premium?
ACA, if you have a bronze plan, your deductible is what now? $7,000 now? It's really high. And what that ends up doing is it puts a burden on those people who end up getting sick and need health care, and it makes it less expensive for people who are healthy and end up not. Even though the premise behind healthcare reform was that people who were sick were not going to have to pay more just because they're sick. That's why we did away with, prior exclusion, prior condition exclusions and so forth. I think we all recognize that if we were designing a system from scratch for everyone, Medicaid is a great model, right? It's got the best benefits, and it's got, for most people, no premium and no cost sharing. The problem is that to do that, it's going to take state money. And so we have to, as a Universal Healthcare Commission, I think we have to look at what are the most important things that we want to provide for people and what the cost of those are going to be, and design a system that, that we're capable of financing.
Okay. And Mohammed, I don't want to miss your comment, question, or statement.
No, actually, it's very well covered by those who spoke before me. I would just add, yes, realistically speaking, I envisioned in the beginning of this journey something like Medicaid for all of Washingtonians, but in the real world that costs money. So we have started the conversation with how much is our state willing to pay for, so that everybody has accessible coverage that really covers their health without making them bankrupt or so. But I also understand everything costs money, and there's a real conversation to be had there. But if in a perfect world, I'd just give Medicaid kind of plan to all Washingtonians, but I don't have all the money.
Thank you. Dr. Chima, is that?
Just quickly, kind of
Is
think
it
all the
me?
points. Oh, can you hear me?
Yes.
Okay, yeah, no,
Yes.
quickly, I think those comments have all been great. I just wanted to add that, it might be important to separate the cost component of the discussion from, since we're kind of thinking about this as starting from designing the system from the scratch, a future system, right? So that you're kind of not restrained by, starting with, oh, what can we pay for? What can we not pay for? That's more of you figure out what makes sense with regards to what is an essential coverage that we should be aspiring to have for everyone. And then come back to the question of, okay, that is great, but how are we going to pay for it? And then you get into the practical questions. If you start with the question of cost, I think it might change the outcome, because then you then have to come up with a figure. But also knowing that what the system can pay for is also a moving target, knowing that there's so much inefficiency in the current system that could potentially free up some dollars if you design a different system in the future. So just to say that we may want to start with benefit design and come back to the question of cost and out of pocket deductibles and all that later. The second point is, it might be important to, I'm just wondering how FDAC is going to approach in regards to We're going to be looking at other countries and thinking, what are we going to be using as that gold standard? No, one thing that comes to mind is maybe to think about this in 2 tiers. Like, is there a minimum package of services that you think, everyone should be able to access without financial barriers, out-of-pocket payments and things like that? And then maybe there's a second tier that then you begin to introduce deductibles, or have maybe a private market for that second tier, whatever that looks like. Or maybe kind of think about it as in a minimum package that you really want to guarantee everyone and remove cost barriers for, and then sort of the add-ons. So just something to think about.
So like kind of like the essential health benefits, but what is the minimum we want to make sure everybody has? But and I'm glad you're here for this conversation, because I keep thinking about population health and how can, we use the universal health coverage to start to address a population health. I worry that people right now, preventive care, no copay. So what if everything's no pay? Are people going to still get their preventive care? So what are the adverse? So I'm sorry, Liz, I think you have some questions for us to answer.
I was just trying to kind of summarize what I feel like I heard from folks. I heard the recommendation about, is there something around 2 tiers for benefits? I also heard a recommendation about wanting to understand, in addition to having the benefits grid, wanting to understand how much individuals have to pay out of pocket before they're able to access those benefits. So not so much how much it's going to cost to actually do that benefit package, but what does it on the individual side look like for them to be able to access the benefits in terms of like deductibles and cost sharing.
So I just want to add one thing. The reason I'm asking for the cost is not necessarily to say, oh, it's too costly and we shouldn't offer it, because that's not the purpose.
Right.
But I think sometimes when you compare even just the cost of providing a service, that you can identify inefficiencies there. So if 2 groups are able to provide a service at different cost and one is at a lower cost, that could be indicative of some inefficiency in the other system. So it's not, we don't have a budget in front of us to say, oh, we can only spend this much. That's not the point, and I don't think we should go there. I think it is important to figure out what is the best we can do, but the realities are that we also have to figure out if there are inefficiencies somewhere. So that's the only purpose for asking, at least for me. I think that's why it's important.
Okay, and I will say, and I know we're at time, but that question in particular is one I know Mandy and the Healthcare Cost Transparency Board are looking at. So there may be information as we're going along where we're going to get an update from them specifically on that question, Vidisha, because it is really important. Yeah, Mohammed.
Oh, no, I recognize that we're over time and want to be mindful of people's time. I just wanted to maybe list your question is very interesting. In a way, can we start with without even repackaging it? Can we just, because we're giving recommendation to the legislator, and this is a call for them at the end, but can we start the conversation at what does it cost? What will it cost us to cover all Washingtonians, regardless of their income bracket? Is that a realistic starting point that we can do? I'm just brainstorming.
So if we look like the Medicaid package and
so start from there and then see how is that affordable, is that realistic for the state, and then maybe we can go from there, and then we'll settle with the best that we can afford at the end.
Liz, it might be helpful for you to reference
the work group.
Yes, exactly. The work group modeling that you had done previously, because I think that might answer Mohammed's question.
Yeah, Mohammed, we can bring that forward. We actually probably should ground everyone in what they did in that work group around the benefits, because I do remember we kind of debated that for a while. So we can look back at that as well. Okay.
And then if people have more thoughts, should they just email them to you, Liz?
Yeah, email them to Mandy because I know she's the main conduit and she'll
Okay.
share them with us. But we will continue to work on this. It's really, this is going to be the, makes it real, I think, for folks. So.
Mhm.
And I know we have a lot of new members, so I just want to remind everybody about OPMA. Please don't use reply all to email me, just email me individually.
Great.
Okay. Well, thank you all for attending today. This was our first 3-hour meeting, and I think it was fantastic. I really appreciate the staff bringing the presenters, the presentation, and all of you for participating in the conversation. The recording and summary of this meeting will be posted on the website soon. Our next commission meeting is April 17th at 2 p.m. And as a reminder, our meetings are extended for this year from 2 to 5 now for the 3 hours. And then the FTAC meetings in the middle, if you want to catch them or if you want to review the parts of them, those are also on the same webpage where our meetings are. So look forward to seeing you all at the next meeting because we'll be out of session. Yay.
Bye, everyone. Thank you.
Thank you. Have a great weekend.